Good morning and Happy New Year. I'm calling this roundtable to order. Today is Thursday, January 4th, 2024. The time is 10 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today's roundtable will focus on persistent challenges in adequately staffing school health suites. DC Health oversees the School Health Services Program, which provides school health suite staffing to 183 schools through a grant with Children's School Services. This program has consistently struggled to staff the health suites at 40 hours a week. This is both due to the national nursing shortage as well as a program budget that is insufficient for employing a full-time nurse in every school. In the 2023-2024 school year, DC Health and Children's rolled out a new staffing model for health suites with the goal of getting to 40 hours a week of staffing coverage for all schools. This new model, based on models in Maryland and Virginia, have RNs as well as LPNs and school health technicians working together in a cluster of 3 to 4 schools in close geographic proximity to one another. Depending on the health needs of the student body, some schools would have a designated RN, while others would have a designated health technician who could call an RN for more serious health emergencies. At a July 2023 hearing, Dr. Andrea Boudreau from Children's testified that she was, quote, confident that the program would be fully staffed by the beginning of the school year. Instead, the program continues to experience high vacancy rates, leaving schools with closed health suites and children with chronic health conditions at risk. As of November 28th, 2023, Children's had filled only 169 out of the 230 full-time positions, representing a 26% vacancy rate. This high vacancy rate is driven by health technicians, with only 67 of the 120 health technician FTEs filled. This represents a 44% vacancy rate. This has led to only 56% of our health suites that participate in the school health services program having 40 hours a week of coverage for full staffing. This lack of coverage is having an immediate and several repercussions on schools and students. I've heard from school administrators, parents about ambulances being called for students who need routine medical attention, and parents, and teachers administering medication for chronic conditions, and health suites being closed at schools for weeks at a time. This is unacceptable. I've called today's roundtable, even though we have a general performance oversight hearing for DC Health later this month, because I believe it's crucial that we give this issue the attention and deep dive that it deserves. I look forward to hearing from the witnesses and discussing some solutions with both Children's and DC Health, who are both here to testify today. Before I get to public witnesses, we've been joined by several colleagues. First, Chairman Mendelson, who is joining virtually. I don't know, Mr. Chairman, if you have an opening statement you'd like to make. Mr. Chairman? Okay, maybe he will join thereafter. We have also been joined by Councilmember Matt Freeman from Ward 3. Councilmember Freeman?
Thank you very much, Chairperson Henderson. I guess we shouldn't start this day without congratulating you for your advocacy on SNAP and the good news that we received last night that SNAP will be funded. So thank you so much for your advocacy on that critical issue. On this one, I hear from constituents all too often about the need for fuller coverage, families where a child might have a very particular need, and the coverage is not complete enough to ensure them the level of comfort that they need. I get it that everyone is contending with a shortage of nurses and we're trying to come up with the best plan that we can. I get it that it's a competitive environment, and I've seen some of the testimony. I really want to thank the chairperson for holding this hearing and pushing on the sense of urgency. Nothing is more urgent than keeping our children safe while they're in our care. And so figuring out how we're going to get to the kind of coverage that we need, I know that's the aspiration that everybody here has. I really want to thank my constituent Libby, who's been a leader on this issue. Thank you very much for your work on this. I'm hoping that today can be productive and we can get to a better result quickly in this area. It's really critical for all of us, and I know we share that goal. So thank you very much.
Thank you, Councilmember Freeman. Chairman Mendelson? Okay, I'm sure he'll join us later. So this is a hybrid hearing. I'm going to call our first panel of public witnesses who are actually here in person. As a reminder for our witnesses, witnesses representing an organization will have 5 minutes to speak, and the witnesses representing themselves will have 3 minutes. For those who are attending virtually, you'll need to proactively accept not proactively. You will need to affirmatively accept our invitation to be elevated as a panelist to be able to join us. But I'm going to call the first panel, Willem Dickey. Sorry if I said it incorrectly. Okay, come on in, Deacon. And you could just come to the table. Libby Bushell and David Hoagland. I have another seat. So if there is another person who wanted to be a public witness, who intended to be a public witness but didn't testify, now is the time to make yourself known. Y'all good? Great. All right, wonderful. Okay, Mr. Dickin, when you're ready, you just hit the button in front of you on the mic. There you go. Yep. Yes.
Okay. Members of the committee and Chairperson Henderson, thank you for hearing my testimony. My name is Willem Dika, and I currently coach the 1st and 2nd grade soccer team at Amadon-Bone Elementary, where my daughter was a student until 2020. Now, I'm here to discuss how the new method under which nurses are assigned to schools is failing the students at not only our school in Ward 6, but also at some schools to which I reached out in Ward 8, schools that have historically been underfunded, in order to understand their experiences under the new model. I learned specifically from one of those schools, Malcolm X, that Amadon is not alone. This past September, the DC Council revoked a 2017 law that mandated every DCPS public and charter school to have a full-time nurse. And instead, a new way of staffing nurse and health professionals was introduced, the so-called nurse cluster model. Under this arrangement, instead of a full-time nurse at every school, a cluster of at least 4 public or public charter schools that are geographically close to one another would share at least 5 total healthcare workers, including a licensed nurse practitioner and a nurse manager. Each school would be assigned at least a full-time health technician. Now, for schools like Amadon-Bone and Malcolm X, this model has failed to deliver on DC Health's stated promise of delivering optimal student health care. Both Amadon and Malcolm X had its full-time nurse reassigned under the new model, and they were replaced by a 3-day-a-week health technician. So with little prior notice, Amadon's tech is frequently assigned elsewhere on days she's supposed to be at the school. On those days, school staff with administration in medication or AOM training wind up having to provide basic care, and kids have to line up before recess for asthma medication at our principal's office. At Malcolm X, I was told that they similarly have a nurse technician assigned 3 days a week, and on the other 2 is replaced by AOM staff who spend all day in the nurse's office, pulling them away from their regular duties. But despite the efforts of school staff, for many kids, the burden of administering some daily medication falls on the parents or guardians absent a nurse or nurse tech. Many of these parents have to take off work as a result. This means that the parents, guardians of the nearly 25% of Amadon students who come from Ward 7 and 8 face long commutes to the school, and for many, working from home is not an option. Their workplaces may only allow limited, if any, time off. So for these parents and guardians, the full-time availability of a nurse tech may mean the difference between keeping their job or having to make the excruciating decision, one which a parent at Amadon, who also happens to be a dear friend of mine, had to make several years ago: quit work to take care of a child with chronic health issues. And for that parent, this meant eventual eviction and a period of homelessness a few years back. And she is not alone. This or that, in part, is why the stakes of this issue are so high. As a soccer coach at Amadon, I contacted the Red Cross so that I and some other parents could become certified in not just first aid, but also in the administration of medications like asthma, because for this upcoming season, there is no longer any certainty that a nurse will be present to treat my students' injuries that occur almost every week. And in case of emergency, I feel a duty to also have at least a Red Cross certification in the administration of asthma medication, asthma being a condition that can be brought on by the physical exertion of sports. So while perhaps no one's intention, the reality is that by filling in on the many days and time periods when neither a nurse or nurse tech is available, the current cluster model is being held together by a vast pool of unpaid labor that includes dedicated parents who have to take costly time away from work, already stretched school staff that in our case includes the school principal, and coaches like me who have had to step in by being trained in the first aid and the administration of medication. There is no substitute for a full-time licensed nurse at every school, but absent that, we ask this committee to ensure that, in paraphrasing the words of the man for whom MLK Elementary is named, at the very least, you ensure that DC Health and Children's International give Amadon Bowen, Malcolm X, every DCPS school what they promised on paper at the beginning of the school year, a full-time health technician operating in a cluster with enough licensed nurses to manage them. This issue is one of not just equity, but of basic fairness. And as it stands currently, the new cluster model for many has not come close to fulfilling that promise. To this end, I would ask this committee to hold DC Health, CSS, and Children's Hospital to account for the cluster model's failure by demanding a full disclosure of the current staffing levels for each cluster, and to ask what steps are being taken to recruit and retain nurses that are leaving DCPS because they are being reassigned away from schools to which they have deep ties and are overstressed from having to oversee multiple nurse techs. I think I've gone over, but I'm sorry.
It's okay. Thank you.
Thank you for your time. Appreciate it.
Thank you. Ms. Bouchel? Mr.
Hi, my
Pickett?
name is,
Hold on one second. If you could just turn your mic off. Yeah. Okay, now go ahead.
Hi, my name is Libby Buckley, and
Oh,
thank
Buckley.
you for letting me speak. And thank you, Councillor Henderson, for organizing this hearing. I'm a parent of 3 children at Jackson Reed High School. I also have a master's in public health and a master's in public policy, and have worked in health systems management, health policy, and contracts management for over 30 years. I'm here today to express my extreme concern over the new nursing allocation plan. In 2016, parents raised objections to a similar plan, and the council enacted a 1 nurse per school model. However, recently the council allowed the DC Department of Health to enact a different allocation formula. I know that there's a nursing shortage. However, the DC Nurses Association contends that nurses like to be housed in schools due to consistent clientele and favorable working conditions, all of which were taken away when this new allocation formula created instability by forcing them to move from school to school. The result, according to the DC Nurses Association, out of 60 registered nurses who started the year, only 40 remain. At the beginning of the school year, there were 40 LPNs, only 20 remain at this time. A survey conducted by the Parents United for School Health, which I'm a member of, stated, a survey of parents showed that many parents have not met with a school nurse to discuss their child's health needs under Section 504. Parents from different wards have stated that their school has little to no coverage. I've heard horror stories of ambulances called to schools to rescue kids who could have just received an EpiPen injection, but there was no one there to give it. Teachers were pulled from classrooms to monitor an asthmatic child who only needs to use an inhaler, but again, there's no one there to administer that. Children are lined up in rows in the front office, vomiting on the floors because the nursing suite is closed and there's no one to attend to them. My kids are relatively healthy, but they sometimes get injured or feel sick at school. In prior years, a nurse would call me to help me assess whether my kids should come home. Now there's no one there. My kids call me and I have to figure out on my own. Our kids are unsafe. An analysis of an early version of the model that I obtained showed that the 1 nurse to 4 schools shows that it does not consider the size of schools. For example, Jackson Reed High School, the largest high school in the city, is in the same cluster as 3 other elementary schools, also some of the largest in the city. Together, this cluster totals 3,914 children. The model allocates nurses to KIPP charter schools in clusters, meaning that their middle school, high school, and elementary schools are being treated like a single school in the DC model, leading to 2,500 plus students over 6 schools that these nurses and techs are supposed to be covering. One justification I've heard for this new model is that it has enabled the city to allocate resources to schools that were having trouble finding full-time nurses. I really support the equity across the city, but that when you peel back the coverage numbers from DC Department of Health, you find that this improved coverage reporting includes health techs who can't make decisions about care, aren't trained to assess conditions independently, and cannot proactively manage the health of at-risk children over time. This model has caused incumbent nurses to leave the system. The entire city is going to pay the price for this with increased healthcare costs as communicable diseases rise. We're also sacrificing the role of school nurses to be able to potentially assess things like an early gas leak in a school by knowing the symptoms that would occur under this time. We can't afford to let our children die. So I urge the mayor and the DC Department of Health to work together to increase the school nurses' salaries and provide more funding in the system to improve retention rates and create some accountability measures in this model to ensure that the promise we received nearly 7 years ago, a nurse for every school, is fulfilled. Thank you.
Thank you. Mr. Hoagland?
Good morning, Chairperson Henderson, Chairman Mendelson, and Councilmember Freeman. I'm David Hoagland, President of the District of Columbia Firefighters Association, IAFF Local 36, AFL-CIO. As president, our highest priority is the health, safety, and dignity of our members, so our members can be at their best for those in their time of need. In previous testimonies, we have always focused our comments around the basic pillars of staffing, training, and resources. Today, I will focus my testimony around the topic of resources. The staffing of school health suites affects DC firefighters and our response capabilities throughout the district. When there is a health suite that is not staffed by a registered nurse, that can lead to a call for help from 911 to administer care to a child in need. This would spark a chain of events that is anything but a model of cost savings for the district. Members of Local 36 would respond to that 911 call and show up to assess and treat a child. Since that child is a minor, they won't be able to refuse our care, which will then lead to a hospital transport unless they have a parent present. That child will need to be accompanied by a school staff member, and then we'll have to wait to be seen. Wait times will be dependent on the volume of patients currently waiting for treatment, along with ER staffing on that particular day. This wait time would needlessly interrupt the child from their learning at school and expose them to other sick patients in the emergency room. Let's not forget that the school staff member is unable to fill their role at the school, leading to other students being affected. The stress placed on both the child as well as the staff member would be unproductive for them and would add an extra burden to other school staff members to do more in their absence. Finally, it's not outside the realm of possibility that during the height of flu season, we could have multiple calls for service. All of this ultimately could have been preventable, as these runs often are, as a result of a regular health condition that a child suffers from that a school nurse could address and then return the child to the classroom. I know that you, Councilmember Henderson, and every member of this committee understands the importance of providing early interventions and preventing a trip to an overcrowded emergency room. Today, I don't have any specific data to share on how many EMS runs we've responded to in calendar year 2023 to learning institutions. However, that doesn't also mean that these calls are not happening. As I've engaged in the process of discovery on this issue, I've had countless anecdotal stories from Local 36 members about these runs. I'm sure if a request was made by the committee to ask for such data from the Fire and EMS department, they could easily provide it. I've experienced incidents like this as an emergency responder and as a parent of a child in the district school system. School nurses provide a whole child-centered approach to care. Their training and knowledge exceeds that of both our EMTs and paramedics. In these positions, they can garner better relationships with the students, as well as working with their parents on specific health history. They are in a perfect position to provide preventative care before calling 911 would become a necessity. Once the Fire and EMS department has been called for, all we can do is show up and treat these children for whatever acute symptom they are presenting with and provide transport. In the case of a more serious emergency, school nurses can provide critical life-saving interventions prior to the arrival of Fire and EMS resources. The district's children are the priority, and their lives are directly impacted by the lack of having a school nurse present full-time at their school. Furthermore, While there may be a cost savings demonstrated by not having a school nurse present at every school, it still costs the district money. They end up paying more in the end if you add up the costs of a 911 response, transport, and hospital stay for the child. I want to conclude my remarks by acknowledging President Ed Smith of the DC Nurses Association and his hard work on this issue to get these school health suites staffed with registered nurses. We are here to support this proactive initiative and its members who do so much good in the realm of healthcare here in the district. We feel this move not only improves the health and safety of students, but can assist also in mitigating additional burden of an already strained EMS system that's running an average of 545 calls per day. It is vital here at today's roundtable that we begin to think bigger on the broader public health implications of this grant functioning effectively and realize it extends beyond just having nurses in schools. Sadly, I feel we have a systemic healthcare challenges, and if it is continued to be left unaddressed, it can lead to a healthcare crisis. This initiative is a responsible way to make positive change. However, we should not stop here. Many small proactive changes can yield much larger changes as long as we stay focused on seeking innovative solutions to overcome our healthcare challenges. Thank you for the opportunity to testify today, and I will happily answer any questions you may have.
Thank you. And thank you so much to this panel of witnesses for your particular testimony. We do a 5-minute round. Is that okay for you? Okay, great. Mr. Hoagland, I want to start with you, if possible. So
Yep.
Just from a process standpoint, I also have anecdotally heard of schools having to call EMS for a particular issue because they didn't have any personnel on staff who they felt like could handle whatever the situation was. Now, from your testimony, you said that because you're a minor, you can't refuse treatment. So does that mean that for any instance when FIMS is called to a school for a student that you must transport to the hospital after?
Yeah, generally, unless we're able to get in touch with the parent and they have some kind of existing consent on file with the school. But otherwise, as some of the other panel members testified, the parents often aren't available because they're at work or something like that. So we just have to operate under implied consent, which is that, hey, this child needs help. There's nobody here to treat them. So we got to take them to the emergency room.
Okay. What if in those situations, if it's like an EpiPen situation, do you still transport after that?
Yeah, I mean, that's a pretty serious emergency. So if you give a child epi, you're going to want to monitor them. I mean, generally they resolve, but there's other side effects to administering epinephrine. So if they've got that severe of an allergy, you probably are going to transport them anyways to get them monitored, unless it's the parents there, or they're pretty frequently given epinephrine, and we already know how the child responds.
Yeah. One of the things I've been trying to figure out is what we have seen in the last few years different than perhaps what we saw pre-2020? I can't ever recall a time sort of in my working in DC government where every single health suite has had a full-time nurse 40 hours a week. I don't think I can't.
Right.
We've never been able to reach that from a staffing capacity. And so I'm trying to understand, is it more health needs that are being raised? Is it a different staffing challenge? Obviously we have that, or something else different going on here.
I mean, it's obviously a multitude of factors. Like you're right. I've been a firefighter in the district since 2007, and we run schools all the time. But you would notice a difference when you get there and there's already a nurse versus not.
Okay.
Sometimes if it's you'll know, like you'll go to a school multiple times a day if the nurse is off, right, on a 911 call if there's issues. If you're going there and there's already a nurse present, it might be a chronic asthma sufferer. And those just be like, and any parent knows who has a child with severe asthma that sometimes just the inhaler doesn't do enough and you got to do more. And, you allude to the staffing challenges, right? We all hear about the tight labor market post-COVID. But one of the panel members too mentioned, like, there's an incredible amount of burnout by healthcare providers in emergency rooms. Like, it's part of why our ambulance wait times are so long, because when a hospital's short nurses, they just stay open. So they're just doing more with less, right? But there's so many nurses, I think, who are attracted to these jobs because it's a better work-life balance. As they mentioned, you're dealing normally, with your same host of patients, et cetera. So I think, there's other things we've employed, right? Like
Yeah.
the nurse triage line. Maybe there's a space for some sort of nurse triage line model within schools.
Mhm.
That's not necessarily ideal, but we've had some luck in getting virtual or having a ready responder respond to runs as we've continued to build out this nurse triage line.
Mhm.
But those I think are some of the anecdotes I can share if that answers
Yeah,
some
no,
of your
that's
questions.
definitely helpful. Mr. Dickon, I want to ask sort of follow up. You mentioned that you and some other parents got trained with the Red Cross around, administration of medication in terms of asthma training, et cetera. At least and correct me if I'm wrong, the DC scores portion is after school, which there's never really been a nurse after school, but you're saying these are around like PE things during the school day. Oh, maybe you just turn your mic on. Sorry.
So this is right now, we have not done this training yet.
Okay.
Okay. I'm working with the PTA to try and fund it because it's not cheap. But the problem is that this past fall, we were kind of lucky that there was a nurse present on days that I needed to take the soccer players to the nurse, right? But right now, I can't be sure that that nurse is going to be present because normally the nurse would be there through the after school practice hours.
Oh, okay.
Yeah.
So in the past, the nurse
Mhm.
had been on site even through the after school practice.
That's correct.
Got
Yes.
it. Okay. That's important clarification.
Yeah.
All right. I'm going to try to practice and good skills. I'm over my time. Councilman Berman, thank you for being here.
Thank you very much. Really appreciate it. I think a number of my questions got answered along the way. One of the questions did go, Mr. Dickey, to what the coverage was after school. And sounds like maybe till 5 o'clock or something like that, if there's a nurse, that nurse would be present.
Yes. Yeah.
Okay. Ms. Bouclet, again, really thank you very much for all of your advocacy on this issue. Can you speak to the Jackson Reed cluster situation? Because it does seem, I looked at the data, 3,900 students covered in that cluster. Who's assigned where in that cluster, and how has coverage operated in the last year in that cluster?
I can get the information for you I think that's a better question for the DC Department of Health as to who's allocated where. I have the on paper information on who's allocated where, but that's a document that was shared with me from another constituency group. It dates from September. So I can't really speak to who's assigned where now. What I've heard is that the names that are on that list are not people that are actually at the school. And so I can't really trust the data that I have aside from the, sort of bare bones of what schools are supposed to be in which cluster.
So this does go to something that when the government witnesses testify, I will ask about, because has been significant erosion from August to the end of the year in terms of staffing, and trying to understand that will be important. So whatever names might have been on the list from September, I don't think it's hiding in plain sight that there's been a lot of erosion that would be different today. You referred to a survey that was done, and I think you said it was of parents.
Yes.
Are you aware of any sort of survey of nurses who have exited, trying to get at why that may have happened?
I have not heard of that. I mean, I went to a meeting with DC Nursing Association, and they obviously point to the lack of stability in the model. They're extremely concerned about, and it is interesting. I was reading the Department of Health's testimony, and they say something there about how these techs are supporting the nurses, which implies that the nurses are somehow supervising these techs and directing them, which is not actually in their job description. And it's not something they feel comfortable doing. So they feel like they're being placed into a terrible position of kind of overseeing people that they're not supposed to be overseeing. And it's making them feel very uneasy and very concerned. And as I understand it, that's the reason why they're leaving the system.
Well, that's the thing. I'll be asking the government witnesses about this, because when you see erosion, like the kind of erosion, and there's some explanations in the testimony, but when you see erosion like that, you do wonder, because it's on the order of a third, I believe, were the numbers. So what is that all about? I think we all need to understand that. Mr. Hoagland, of course, I was going to ask you how many calls and how much does it cost? And then you said, well, you don't have that information, but I saw the chairperson Henderson make a note when you said this was information that we should seek. And so I think that's super important, because you can rob Peter to pay Paul. And we don't want to rob Peter to pay. Nobody wants to rob Peter to pay Paul. So thank you for your testimony. I guess there's another dimension, and maybe it's a thing that we could ask about, is how many 911 calls go to schools, because OUC is another agency that is overburdened. Now, it may be the same data. It may be every call that tells you how many there were, and calls over time, I think, would be interesting to see. I want to thank all three of you for your testimony. Really appreciate it, and look forward to hearing the testimony of others today. Thank you.
Thank you.
Thank you, Councilmember Freeman. Thank you so much to this panel of witnesses. We're going to call I'm going to plan ahead for folks. So we're going to call the next panel, which will be our final panel of virtual. We'll take a brief break, and then we'll get to the government witness. Great. Sarah Buckley, Elizabeth Mitchell, Vanessa Medina, Diane Harris, Ebony Rose Thompson, and Eric Goulet. So again, for those, you have to affirmatively accept our invitation to become a panelist in order to join. And Councilmember Freeman, I will just say, we have requested call data from FIMS in the past. They've been incredibly responsive. It was on opioids, not on schools. So we'll ask a different question, and hopefully we'll share what we get. Okay. Why don't we go ahead and get started? I see Sarah. Sarah, if you want to.
Good morning. Can you hear me?
Yes, ma'am. Good morning.
Good morning. My name is Sarah Buckley. I live in Southwest DC with my two kids, including a kindergartner at Amadon Bowen Elementary School. And I wanted to offer our personal story as an example of how the cluster model and the Department of Health's mismanagement of the school nursing program is failing us. My son has several life-threatening food allergies. And in past years, when we have met with our school to discuss his 504 plan accommodations and his anaphylaxis action plan, our school nurse, who had been with the school for 10 years, had attended. During that meeting, she would revisit his conditions, his medications, and she's offered training to our son's teachers on recognizing and responding to food allergic reactions. This year, a week into school, when we had this meeting, there was no nurse, there was no health technician, there was no one from the school nursing program at the meeting. There was no one in the school health suite for the entire first week of school. When we did have a health technician assigned, I asked to meet with her to discuss my son's allergies and his anaphylaxis action plan, and she hesitated because she was not sure if her placement at Amadon would be temporary or permanent. It turns out it was temporary, and as my friend Willem noted, was part-time. She was assigned only 3 days a week to our school, leaving us with no one the other 2 days. And I learned this morning that she has now left, and we are currently being staffed with a health technician that is otherwise assigned to a nearby school for 2 days a week. In December, I received a call from a different technician telling me that they did not have my son's doctor's orders for his medication and his EpiPen on hand, which are forms that I provided to the school and to our initially assigned nurse technician at the beginning of the year, meaning that more than halfway through the school year, no one had looked at or processed the paperwork that we had submitted, and that his EpiPen and his Benadryl was just sitting there with no direction and no orders about how and when to use it. There's undeniably dysfunction and severe mismanagement in the school nursing program. The Department of Health and Children's School Services need to take action now and treat this situation as the crisis it is. But I also believe that the cluster model itself is fundamentally flawed and doomed to fail for two main reasons. First, as earlier witnesses noted, the health technicians are not trained or licensed to assess children's health situations. They can administer medication, they can hand out Band-Aids, but if a child comes in with hives and stomach pain, will they be able to determine that those are symptoms of anaphylaxis? Because that is how my son's 4 anaphylactic reactions have always begun. This gap in licensing will lead to schools over-relying on EMS and can put my son's health and other children's health at risk. Second, I think the cluster model will fail and is failing because it's not realistic to expect a single RN to supervise 3 health technicians across different schools and be familiar with the health needs of 4 different schools. The pressures guarantee that they will burn out and leave. And so I see my time is up or almost up, and I wanted to leave some questions for this committee. This committee needs to demand to hear what DOH's plan is to ensure that CSS recruits and retains enough staff to serve every school. It needs to ask what DOH is doing to ensure that it has accurate information about the medical needs at every school, accurate and up to date. This committee needs to reinstate the Public School Health Services Amendment Act to ensure that every school has a full-time nurse, or at least that we have a legal mandate to do so. And this committee needs to provide sufficient funding to attract and retain quality health providers at every school. And finally, if CSS and the Department of Health are not delivering the services that they're obligated to under the law, will this committee recommend a competitive bidding process to ensure that we have service providers who will meet the needs of the district? Thank you.
Thank you, Ms. Buckley. Ms. Mitchell?
First, I'd like to once again encourage council to create avenues for families, teachers, and staff who would like to testify on subjects like this that involve highly personal and private issues to do so either anonymously or privately. It's hard enough to discuss these issues with anyone, let alone in a public forum where we are forced to lay bare our pain and discuss issues that truly belong to our children. There are a number of people who can't testify today, so I will try and elevate some of their concerns as well as my own. Several families have told me they've already left or are planning on leaving DCPS because they know their medical challenges cannot be handled by the current plan. One family was flat out told by their school that their child's needs would not be met. They didn't feel comfortable testifying today because they didn't want to out their school and get them in trouble. Another family has a child with a deadly food allergy. While the school has the required 3 staff members who can administer an EpiPen, they live in constant fear of a day when one or all of those staff members will not be at school or out sick. They witnessed such a day last year when every lead teacher in their grade was out sick for an entire week. One of the biggest issues we see at my child's school is having sick children return to the classroom because there's simply no adult to sit with them in the nurse's suite. We've had several incidents where children have barfed in the classroom or in public spaces, often several in one day. I learned this year that if a child barfs at school, they don't necessarily get sent home. Our school is supposed to get a nurse once a week and health techs on at least 2 other days, but the burden of medication and healthcare falls on our staff members and often teachers who are dragged away from their classrooms to care for students and the mess created by sending sick students back to the classroom. I can't even tell you how many days my elementary school student has been home sick this fall because of this lack of coverage. He has asthma that requires him to use inhalers when sick. If he has a cough at all, I can't send him in because although he's old enough to self-administer his inhalers, he isn't allowed to at school, and there's no guarantee there will be an adult there to get his medicine for him. With the typical school year, I would have met with the nurse before school started to discuss his action plan. That didn't happen this year. When our school had a nurse, she not only diagnosed my son with asthma, but later correctly identified one of his medicines as the source of his behavior problems. This brings up another huge issue. Under the prior system, our school nurses have often helped identify mental health issues in our students. Frequent visits to the nurse's office with upset stomachs and headaches are often caused by anxiety and other issues that are handled by our student support team. When we had a nurse, she was able to work with the team to properly ID these issues so that she could get back to serving physically sick students rather than students that were having emotional problems. This no longer happens, and we all know that there are more of these issues now than ever in the wake of the COVID pandemic. I've also heard from several teachers who are either already AOMs or would love to get that training, but there's no time or incentivization. 2 of the teachers who are AOMs are thinking of leaving DCPS because they know they will have the support they need in neighboring counties, and they also are stressed about the burden that they currently bear. Having to leave their classrooms to go treat a growing number of students is also negatively impacting their own students and their ability to meet their teaching goals. Thank you.
Thank you. I don't see Vanessa Medina. But Ms. Harris?
Hi, good morning, Councilmember Henderson. I am going to do a joint testimony with Principal Spears at our Blow Pierce campus. My name is Diane Harris, Director of Health Services for Friendship Public Charter School and a Ward 8 resident of the District of Columbia. Thank you for organizing this oversight roundtable. I've devoted the past 25 years at Friendship to ensure that our 15 campuses on 9 sites have seamless structures in place for health services and student support that are conducive to our academic achievement. Friendship prides itself on a whole child response to the academic, physical, and emotional needs of its 4,500 students, 50% of whom are medically fragile due to diabetes, epilepsy, asthma, and social and emotional issues. Challenges that we have. School nurses who have worked within Friendship between 5 and 20 years have all been reassigned, leaving the school community with no transition plan in place and grieving the loss of these valued school community members. Losing our long-term and trusted nurses has disrupted day-to-day school health service operations and the entire school culture. Parents, students, and school administrators have depended on health professionals to address medical concerns. The new staffing model has undermined our school culture, most egregious, and has caused our students to be neglected. Academic leaders at campuses are being distracted as they assign non-medical staff to address medical emergencies, immunization compliance, and administer medication to students, which is beyond their scope of work. School nurse coverage is sporadic, which has fragmented the relationship between the school and our community partners. When there is temporary coverage, they are inexperienced and not able to provide the quality of service our students need. The best nurses, managers, and case managers have steadily been leaving Washington, D.C., telling us that it is because of the chaos and inability to connect to a school as they are routinely moved from place to place. In nearby districts, the pay is better, schools are fully staffed, and nurses are able to provide immediate care coordinated with the child's personal physician. Compassionate and skilled nursing RNs have been replaced with minimally trained, some as little as 2 week student health technicians. Student health technicians are poorly prepared to manage health services for campus with upwards of 500 students. We're finding that too many lack experience and interpersonal skills to make students, staff, and parents trust in their presence and believe in their skills. Schools are reduced to phone coverage when there is no coverage as the temporary solution to student care. Schools need 40 hours of nursing coverage. Moving forward, it is our hope that the Committee on Health, upon a small group consisting of government officials, school nurses, and school leadership who can come together with their unique perspectives and create a collaborative plan that is in the best interest of our students, their families, and the city. Thank you for your time.
Good morning, Councilmember Henderson, committee members, and staff. My name is Gregory Spears, principal of Friendship Blow Pierce Academy, which serves over 530 students ages 3 to 14. Thank you for organizing this oversight roundtable, and thank you, Diane, for sharing your time. I've devoted the past 11 years to Blow Pierce and to creating a community institution that cares about all aspects of our students' lives. We know that children cannot learn if they are hungry, tired, sick, or upset. Every staff member who walks through our doors actively wants to work with children to make sure those basic needs are addressed before we address the academic needs. Blow Pierce has been a Tier 1 school since 2014, and Tier 1 is not just about academics, it's about the whole child. Blow Pierce enjoyed the caring services of Nurse Reed until her retirement in 2022. She was a pillar of our school community long before my arrival in 2013. When Nurse Reed retired, she was replaced by an excellent nurse who was perfect for our school community. She quickly got to know our students, their parents, our teachers, and our leadership team. Despite our written request to keep her with this new model, she was transferred to another school as part of the new staffing model against our collective wishes. We didn't know who was replacing her until 2 days before the start of the new school year. The new health technician had no orientation and lacked the skills and flexibility required of a school nurse. She wanted specific hours and times that were not realistic when working with 530 high needs children ages 3 to 14. As anyone who works in education knows, this is not always a 9 to 5 job. Rather, it's a passion and a calling. Since then, we have had a series of health technicians who at times lack the level of training and compassion that Below Peer students need and deserve. Regrettably, their lack of experience has resulted in the mismanagement of patients. Transparently, we have also experienced technicians whose lack of compassion and empathy have resulted in staff and students avoiding the nurse's office altogether. After having decades of gentle, dedicated, and experienced nurses, we find the current situation untenable. We know that the various district agencies that are working on this issue are doing the best they can, but we still need help. I respectfully request your support in finding a competent and compassionate RN for the Friendship Below Peers community. I support Diane Harris's call for the Committee on Health to appoint a group of government officials, school nurses, and school leadership to collaborate on a health staffing plan that is in the best interest of our students, their families, and the city. Thank you for your time.
Thank you, Principal Spears. Ebony Rose Thompson.
Oh, good morning. It's still morning. Thank you to the Health Committee for having this roundtable. My name is Ebony Rose Thompson. I do represent Ward 7 on the State Board of Education. I also serve as the president of the board. I am testifying in my individual capacity this morning. In 2022, when the new staffing model was introduced, it was with the intention of providing consistency in healthcare services within our schools. However, the concerns I'm hearing from Ward 7 schools, including Below Peers, which I represent, tell me this model has fallen short of its intended goals. One of the primary objectives of the new staffing model was to ensure a consistent presence of school nurses in our schools. Unfortunately, the reality we face today is quite the opposite. The consistency envisioned has proven elusive, leaving our students vulnerable to health uncertainties. School nurses who play a vital role in promoting the well-being of our students are struggling to meet the demands imposed by this model. And schools are often not receiving consistent communication around when they will be staffed and who will be staffing their school communities on a daily basis. Moreover, it is crucial to recognize that school nurses, just like everyone else, are not immune to the staffing challenges that have plagued the broader medical community since the onset of the pandemic. The heroic efforts of healthcare professionals across the globe have been well documented, but the strain on their resources has also been immense. School nurses are an integral part of this larger healthcare system, and grappling with the increased workloads and their ability to provide quality healthcare is paramount. We have only seen increases in the inconsistency of staffing since the pandemic, and we in this model has not addressed the challenges around consistency. Equally concerning is the failure of the new staffing model to account for equity within our schools. Health disparities among student populations are a stark reality, with some schools, many of my schools, facing greater challenges than others. In many ways, this new model has inadvertently overlooked these disparities, leaving certain schools at a disadvantage when it comes to accessing critical healthcare services. I've heard from schools, despite the demographics of their populations, are still being told that they don't have enough students with asthma or enough students with certain healthcare challenges to warrant a school nurse being on their premises. Or even when their texts are out, they're being told, oh, contact your neighboring school and call and get telehealth services. I'm not sure what the bar is for enough of a healthcare disparity to warrant a school nurse, and that should be clear. We must recognize that the health and well-being of all of our students is not negotiable. Every child, regardless of their socioeconomic background or the school they attend, deserves access to a consistent and high-quality nurse in their school. School nurses are the frontline defenders of our students' health, and we must ensure they are equipped, supported with the resources and necessary spaces to do their duties. In conclusion, The importance of our school nurses cannot be overstated. We have not lived up to the promise of a school nurse in every school. And we need to reevaluate the current staffing model, addressing its shortcomings and realigning it with the needs of our students. The challenges faced by school nurses mirror those of the entire healthcare community, and we need the council and the mayor to step in and make sure that we're fully funded, that we're acknowledging those challenges, and we are supporting a model that ensures consistency. I thank you all for the time today, and I look forward to taking any questions, especially speaking to specific things I've heard from schools. Thank you.
Thank you. Mr. Goulet?
Good morning, Chairperson Henderson, Councilmember Fruman, and Council staff. My name is Eric Goulet, the Ward 3 representative for the DC State Board of Education. I am delighted to join you at today's Committee on Health Public Oversight hearing to provide testimony on the DC Health Grant to Children's School Services to staff school health suites. I will be testifying in my individual capacity today as a Ward 3 representative and not on behalf of our collective board. I'd like to start by thanking you, Councilmember Henderson, for holding an oversight hearing on this very important topic today. The residents in Ward 3 are very concerned about the new nurse cluster staffing model, which I can best describe as traveling nurses that are on call to address chronically understaffed health suites in our public schools. I've heard from Ward 3 parents during my service as DC State Board of Ed rep this year, and then from parents across our city during my time as Committee on Health Director from 2017 to 2022, that parents want a full-time 40-hour-a-week school nurse in every DCPS and every DC public charter school. Parents do not view allied health professionals or health technicians as an acceptable substitute to a full-time school nurse. During my sidewalk office hours this fall, I spoke with over 200 Ward 3 families to solicit their feedback for the measurable outcomes and data they wanted to see on the DC school report cards, which is right now before the state board. The average number of hours a school nurse is on site was one of the top issues mentioned. It was mentioned 14 times by parents and students out of that sample set. Parents were particularly concerned about a medical emergency occurring at school when a nurse was not on site. The Office of State Superintendent has agreed to include this metric on our DC school report cards, but our goal should be to eventually solve the problem, not just try to measure it through our report card database. While I was working on the Health Committee as its committee director, and I believe you may have been with Councilmember Grasso at the time, Councilmember Henderson, I wasn't sure of that. I was very proud to work with Councilmember Grasso, perhaps yourself, and Councilmember Gray to mark up DC Law 22-61, which was the Public School Health Services Amendment Act of 2017. As you know, this required a 40-hour-a-week full-time school nurse in every public school. The legislation was approved subject to appropriations, and the committee was able to add funding to the bill on multiple fiscal years. Unfortunately, the largest constraint in fully funding and implementing the bill wasn't the issue of reallocating the funds to cover the cost of the legislation. It was the challenge of attracting and retaining high-quality nurses during a national and regional nurse shortage. As I witness in my professional capacity with United Medical Center, there is a very competitive environment for nurses, particularly after COVID. Whether it be through hiring full-time nurses as staff or trying to contract with nurse staffing agencies. I would be delighted to work with the committee in my capacity as Ward 3 member of the DC State Board of Education to develop solutions to the nurse staffing issue that we are seeing throughout our DC public schools right now. I have two short-term ideas and then one longer-term possible solution to this challenge we are facing. And I was excited to hear from the public today and looking forward to hearing the government testimony about the other ideas people have to solve this problem. And one solution is obviously to increase the pay of nurses contracted through DC Health with children's that staff our public health suites. A second idea that I think would really be worth pursuing is expanding loan repayment opportunities for nurses that choose to serve in our public school system. I think this could go a long way to attracting and retaining nurses if they know their loans will be forgiven if they serve our schools and work with our children. Lastly, a longer-term solution would be to create programming within our public schools that connects to the University of the District of Columbia or other universities within DC to create a career pathway for any student interested in pursuing a career in nursing. I think that would be really exciting to get our local DC youth involved in nursing because it's something that's in high demand right now in our city. Thank you for scheduling this hearing. Again, Councilmember Henderson, I think it's a very important issue. That it concludes my written testimony, but I'm happy to answer any questions that you or your council colleagues have for me today. Thank you very much.
Thank you, Mr. Goulet. And thank you so much to this panel of witnesses. For the public, we've been joined by Councilmember Zachary Parker from Ward 5, who's a member of the committee. So we have more people on this panel, so we'll do a 7-minute round. So again, I want to thank all of the public witnesses who have testified. I'll start with Ms. Buckley. I appreciate you being here and sharing your story in terms of your son. Sorry, I'll just say your child. So I can't quite remember if it was a son or a daughter. And I just wanted to go back to something that you mentioned in your testimony, or at least that I picked up, right? So you and your family had done everything right in terms of providing the appropriate paperwork to the school on time. You reached out to have the conversation, and then you realized that nobody actually touched the paperwork, which kind of made me think to myself, why in 2023 are we still using a paper-based system as opposed to the electronic health records that everybody claims that we were supposed to be using already? At this stage in the school year, has the situation been resolved at your child's school or for your young person?
No, and thank you. Yeah, it is my son. I went this morning to check in because I knew that this testimony was coming up, and that is when I learned that we have the new health technician. So I talked to her about the paperwork problem. I forwarded her copies of it, so that will hopefully be resolved now. But then I also checked with her to verify that my son's medication was in the office. We spent about 10 minutes looking. It was not in the drawer where it is supposed to be stored. It was not in the drawer where the other medication was stored. We eventually found it on her desk behind her computer. So I'd say there are still issues and there is still mismanagement. And despite the cluster model, providing an RN that is supposed to be overseeing our schools, I have never, before the December call about the paperwork, been contacted by the RN. I've never met the RN. I've never seen the RN on site. I think that that's evidence that it is, again, unrealistic to expect an RN to be able to oversee all of them, or is at least evidence that the model is not being implemented in the way that it was promised.
Got it. Understood. But thank you again. And Ms. Mitchell, thank you so much for being here too, and for uplifting the voices of other folks. I mean, well, look, I heard you at the beginning at the top in terms of making it possible for people to submit anonymous testimony. And so we'll certainly look into that with the chairman's office to see if we can progress on that front. Ms. Harris and Principal Spears, thank you so much for being here. I wanted to ask you this question, Principal Spears and Ms. Harris, because you're coming specifically from LEA. This is not the first hearing that this committee has held on school nurses. We did two last year, one in conjunction with the committee of the whole, and we did a hearing prior to the school year starting. And one of the things that was kind of an impetus for the move to the cluster model was because, at least we heard from a lot of school leaders who were frustrated from the previous school year with the number of temp and travel nurses that were in and out of buildings. Do you feel like this is more unstable than what was happening with temp and travel nurses?
I would say so, for sure. The number of issues that we've had far outweigh any that we had with that model at the time.
Okay. Now, prior to the cluster model, did Friendship Low Pierce always have a full-time nurse
Yes.
for 40 hours?
Yes, Nurse Reed was here. She was a full-time nurse. As I stated, I've been here since 2013, and she preceded me here. She was here long before I started, so she was a pillar of our school community.
Okay. Ms. Harris, for the other campuses for Friendship Charter School, did you always have a full-time nurse for all of those campuses?
Yes, we did. And
Okay.
all reassigned.
And all of them were reassigned?
Yes.
Okay. I'm gonna ask some further questions around this. Mr. Goulet, I feel like you and I have had some history on this longer than others because we worked on that legislation a number of years ago. What is interesting to me, and maybe you recall this even then, is that one, at the time, DC Health felt that a full-time nurse in every school was not necessary. And two, we pulled up the FIS from that legislation that passed, which is far less than what we currently pay in the Children's School Services Grant. And how do we square this? Because clearly that was 2017. So that was pre-pandemic, sort of an upheaval in the public health space. But at the time, oh, no, just kidding. Hold on. The FIS was written weirdly. Okay. So at the time, Department of Health had $19 million budgeted for school nurses. That was in 2018. And the FIS said it would be an additional 13 million in order for them to be able to do a full-time nurse in every school. Is this something you still feel like we should be fighting for?
Yes, great question, Councilmember Henderson. And the answer is unequivocally yes on it. And I think the fiscal impact statement's a bit overstated because as we lost allied health professionals through attrition, we could have backfilled those through school nurses. So I always felt that, if we work diligently to staff up our nursing population, it wouldn't have been quite as much as they were estimating. And it wasn't a barrier, as we worked with you, we worked with Councilmember Grasso on this. I mean, you mentioned the department's reluctance to do this. I remember Dr. Nesbitt was not supportive of the idea of moving to full-time school nurses, but the committee and parents believed it was absolutely necessary. So we agreed to disagree on that issue with her. And, I think this is something that we really do need to pursue right now. And I would look forward to working with you and your great team at the Health Committee on solutions that our state board could partner with you on. I mentioned a few today. I think there's some other good ideas at the hearing here, and we would be happy to support legislation that the council would put forward to address this issue. And we've got our great president of our state board here, Ebony Rose Thompson, on as well. And she's a big supporter, obviously, of getting school nurses in all our schools. So I just want to thank you for this. And a long way of answering your question, but short way is yes, we should pursue this. And we're excited.
Let me ask one other question, though, because I worry the issue that we have with school nurses is the same issue that we have with school-based mental health professionals, right? We have fully funded the school-based mental health program, and yet they still have, I think, 30 to 40% of a vacancy rate there. So I could still fully fund full-time nurses in every school, and I still not have a person in every building. So I guess I'm saying that out loud. It's not really a direct question, but I think that we need to sort of contend with that even in some of the programs that we have fully funded, we still haven't been able to find the qualified professionals to be able to deliver one for every school.
I think it's a great point, council member. And maybe when we hear from, I think, some of the representatives later today, if we can learn what the barriers are, why we're losing people. I think one great thing that was mentioned today was that people are frustrated now that they're being shifted from school to school, and that may be adding to burnout. But if we can understand what the barriers are to attracting and retaining nurses, other than just cost, because I think one is salary, that certainly does help. But
yeah,
we learn what those are, then maybe we can tackle them. I think loan repayment might be a good issue. We've done that for underserved communities in the city, and I think it's been very successful. in terms of attracting and retaining professionals in those underserved areas. So maybe looking at expanding that legislation to include our public school system might be another way just to try to incentivize nurses to come look at this, because the unfortunate reality is, a qualified nurse can get a job anywhere they want almost right now where they're qualified. So we have to create an attractive environment that they want to work in. And I think addressing any challenges that are preventing them from getting the full experience is important.
Ms. Harris, I think you mentioned, and I'm sorry, Phyllis, I'm going to wrap up here. I think you mentioned, Ms. Harris, that PG County increased their salaries.
Yes.
Okay. Interestingly enough, that is mentioned in some of the witness testimony as well. Do you happen to know what that salary range is? I went on the PG site to pretend like I was applying just to see what the range was, but it wasn't there.
No, I don't have that information on me at hand.
Okay. I think, I think in a jurisdiction such as ours, where we sit in between multiple school districts, this is a type of price comparison that we have to continue to do. We do it for firefighters. We do it for police officers. We got to do it for teachers. We also have to do it for school nurses. But again, I'm over my time. Councilmember Freeman.
Thank you very much, Chairperson Henderson. Ms. Buckley, thank you very much for your testimony. I'm really sorry to hear that you and your family have had to go through this. Ms. Mitchell, again, also, thank you very much for your testimony. As I was listening and you were talking about folks being reluctant to come forward to talk about their personal issues, so it made me think, and this isn't so much a question, but just an observation, that, when I was a kid, I was horrified when attention got brought to me. And so if an ambulance came to my school to attend to a health issue for me, I would have wanted to climb under a rock. And so there's a cost there that's not just about the cost of the ambulance, but there's a cost to the disruption at the school and to the feelings of the child. So we want to be able to address these kinds of issues in a context of privacy and caring, not with sirens or ambulances pulling up to the school. Ms. Rose Thompson, thank you also for your testimony. You talked about some of the equity issues, and I think you alluded to, there may be places where there are higher needs, kids with more medical needs, and maybe not getting the coverage in those places that we should be. Can you speak to that? And can you speak to how it is that we know what the level of need at a different school is?
Yeah, I've heard from more than one principal that they're being told they're not needy enough, which is suspicious to me. So when we're able to look at things like how many students have asthma, or even knowing how many, when you look at Ward 7 being really a desert of many kinds, including a healthcare desert, school nurses really are our safety net. And I've raised the question of being told not needy enough because I wasn't clear that that was a actual bar. What does that mean? And so there have been instances where one school in a cluster is told, oh, well, you'll pretty much, you don't have a nurse because this, just call the other school and they can respond to you, but the community is the same. And so being clear about if this is a measure that's actually being used, being clear about what that is, but also just I question that being a measure kind of in the first place. I don't know. It doesn't matter if 20 kids have asthma or if 2 kids have asthma. If one of them has a big asthma attack, then you want to have somebody there who's prepared to deal with it. I think the other thing that I didn't speak to, but I do want to be lifted up because I feel like it's kind of a unseen linchpin here is a question of the managers and who's managing and making these decisions. I've heard a lot of frustration from some of the nurses themselves about the management. And so when I think about the question around Ms. Buckley's testimony and the records or even the communication, the managers are the ones who are supposed to be popping in and managing those health suites. And so I don't know how we're able to answer some of the questions the council is providing. If we're only focusing on the nurse itself or individuals and parents itself to lift up, I think we need to have some real questions about like the flow of information and like the management of this proposal.
All right. Well, thank you very much for that. Ms. Harris, Principal Spears, I was really troubled to hear your description of having people come to the school who you felt, I think the word you used was callous or somehow not sympathetic to the students at the school. And I wonder, without talking about any individuals, to what extent does the school interview people before they get assigned to the school? To what extent does the school have the capacity, if they're unsatisfied with the person who's assigned, to get someone new put in place? How does that work in terms of your relationship with the Department of Health and Children's when there might be issues around an individual assigned to your school?
So I can't speak to the interview process, selection process. To my knowledge, the nurse showed up one day and they said, "This is who your nurse is going to be." But in terms of the other piece, I think it's to couple with Ebony Rose Thompson, it's a communication issue. When we've had issues, we've communicated with the team member, the team lead through Children's School Services, and really with no result.
Right.
If we get a response, it's more of a, that's on the school's fault, or that's the school's responsibility. To be more specific, we had our students arrive at 7:30 a.m. every morning. We had students that when the nurse would come in the morning and she would go to the nurse suite that needed attention, needed medication, would go to the nurse suite, and they were told that they weren't able to be seen until 8:15 when the work day starts for the nurse. So we communicated that to the team lead, and we were told basically that that's the way it is. So now we have students in our building up to 45 minutes who may require services that are being refused services. Now the nurse doesn't even come in until about 8:15. They just sit in their car in the parking lot. And to me, that just sends a number of messages, but is also very problematic and creates an unsafe environment where students need services between 7:30 and 8:15. We're left kind of having to act as nurses ourselves, and we don't have the necessary medical training outside of our AOMs that are in the building.
And just to piggyback on Principal Spears, I get oftentimes, when principals are very unhappy with their school nurses, my role is to go through the chain of command with going to Children's and then ultimately to DC Department of Health. That doesn't guarantee that the nurse would be replaced. And oftentimes because of the shortage, that we may not get a nurse for the remaining of the year if the principal requests that the nurse not, come back to the school due to whatever reasons that they have. But we've had instances where nurses were removed from friendship, and we have not had coverage for the remaining of the year. And we had temporary nursing coverage.
All right, thank you very much. Chairperson Henderson, if I can go for just one more minute. So,
Sure.
Mr. Goulet, thank you very much for your testimony. Thank you very much for your work on this issue over the years. You made a couple of suggestions about things that we can do. The increased pay, I think, I have a feeling we saw an increase in pay. We just saw a negotiated contract, but that doesn't mean if we fall behind other jurisdictions, that's a thing that we need to keep in mind. Thank you for that. The loan repayment, I guess one thing that worries me about that is that there's a nursing shortage everywhere. And so if we need this position to be attractive, but it could be another one of these robbing Peter to pay Paul. Maybe it's if they're public employees or they're contracted by the government. Maybe that makes sense. I'd like you to there, but that's a thing that's on my mind about them. Maybe you can speak to that. But also your point about pipeline and your point about using UDC perhaps as a way of strengthening the pipeline of nurses. I wonder if you could speak to that and And if you have any specific ideas or more suggestions about how we might try to pursue that, as you may know, supporting UDC in and of itself is a goal for the city, but using it to fill critical needs. Councilmember White had proposed, and it's now law, in the social work space. Maybe there's more we need to do in the nursing space. I wonder if you could speak to those things.
Well, I think great questions, Councilmember, and thank you for your leadership and partnership on this issue. The issue of trying to compete for nurses is a very real challenge. I mean, you've seen wearing my other hat with my professional role at UMC, you've seen contracts come over, from us that on nurse staffing agencies that have increased, and they've increased because the per unit cost of nursing services has become more expensive. It's harder to attract nurses, and that's a huge challenge that we face here. It's a challenge I think that Councilmember Henderson raised, where we're trying to compete with our region, and I do want to rob Peter to pay Paul on that, and get all the high quality nurses to come into DC, work at our hospitals and our schools, and then that's the suburbs problem to deal with, not ours. So that's something that I would like to try to do, is figure out how we make this the best environment for nursing. And on the issue of trying to get the pipeline, Councilmember, I'd be excited to work with you and your team on this issue, because we have UDC right in our neighborhood, and I think there's such an opportunity, particularly with your proposal, even to try to obtain the Whittle School, which is something I'm excited about trying to pursue. Partnering with UDC to create space for partnerships with our public high schools. This is, a career path that students really could get excited about, because there's a high-paying job waiting for them at the end of that pathway. And if we can show our students this, if we can, allow them internships over the summer, after school with our nursing community here, I think they'd be very excited about this. And I think it would open a lot of students' eyes to, the great value they have for society and for their own personal careers by getting into nursing. So I'd love to pursue that with you and with Councilmember Henderson, and just thank you both for your attention to detail at this hearing today.
Thank you very much. And I went way over 1 minute, so apologies, Chairperson Henderson.
Thank you. Councilmember Parker.
I want to thank everyone for their testimony, and I am not going to ask questions. And I'm looking forward to our government witnesses' testimony. So thank you all.
Well, all right. Well, thank you so much to the public witnesses for your testimony. For anyone who's listening who wasn't able to testify, if you go to the council website for the hearing site, you can actually upload your testimony there for the next 2 weeks, and we can make that part of the record. As I alluded to at the beginning, we're going to take a 5-minute break, and then when we get back, we'll hear from our government witnesses. So thank you.
I mean, I'm happy that. Yeah.
Okay, and we are back. All right, we will now hear from our government witnesses. Okay, so Dr. Ayana Bennett, who is the Director of DC Health, Dr. Andrea Boudreau, who is the Chief Executive Officer of the Children's Schools Services at Children's National Hospital, Dr. Nathaniel Beers, who's Executive Vice President of Children, excuse me, not the Executive Vice President of Children, the Executive Vice President of Community and Population Health at Children's National. And I think you three are the only one who are testifying, yes? Are you just here for questions? Okay, wonderful. But before we begin, so I'm going to ask you and everyone on your team who might answer questions to be sworn in. So if you can raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. Dr. Bennett, why don't you begin?
Good morning, Chairperson Henderson, council members, Councilmember Furman, and staff of the Committee on Health. As you said, I'm Ayana Bennett, the Director of the DC Health Department. I'm pleased to be before you today and discuss the implementation of our updated school health suite staffing model. Before I go on and give you a little bit of history, I just want to be very clear that the staff of DC Health and myself are very much in support of this model. We are implementing something new, which has issues with it, but we are very committed to seeing it through and to seeing it implemented in full. In June of last year, my agency presented before you a planned change to the school health suite staffing model, which began in August. This update was in response to the long-standing challenges by healthcare providers in the district to find enough qualified nurses to meet demand, a challenge that is national in scope. Just want to pause there to say, when we are robbing Peter to pay Paul, we are robbing, the Paul is us, the Peter is us. It is all us. So it is not a choice between us and some distant county. It's us and us. So in 2022 survey by the National Council of State Boards of Nursing and the National Forum of State Nursing Workforce Centers highlighted that over 200,000 experienced registered nurses, RNs, and over 60,000 experienced licensed practical nurses left the national workforce between 2020 and 2022. The same survey reported that roughly 20% of the total RN LPN workforce plan to leave nursing over the next 4 years. By 2030, researchers anticipate that there will be a deficit of nearly 1 million nurses for nursing jobs. While the pandemic has accelerated the pace of nurse burnout, this shortage is very long-standing. Just want to say I checked before this hearing how long it had been. It had certainly been over the decade that you were discussing, Councilperson Henderson, but it has also been at least 15 years or at least 20 years, depending on the staff person and how long they've been here. So this is a very long-standing problem. Due to this shortage, the district has struggled to find an adequate number of nurses to provide in-person coverage of school health suites for over a decade. We have used all the resources at our disposal, including staff augmentation contracts, yet last year, approximately 40% of our school health suites did not have full-time in-person nurses. Recognizing that the staffing level is not ideal, DC Health took action to enhance student and school support. Beginning this fall, a new staffing model was introduced, adopting a team-based care approach. The model mirrors the collaborative care structures that exist in clinics, hospitals, and other healthcare settings. The future of school-based health services is team-based, and almost all of our regional and educational agencies have embraced the team-based model due to a severe shortage in nursing professionals. Under this model, a consistent team of 4 or more professionals, including at least 2 nurses and 2 health technicians, is assigned to 4 schools within close geographic proximity. Each school health suite has a full-time staff member in the building, in the model, 5 days a week, with nurses being prioritized for the schools with medically fragile students. The new role, health technician, is an experienced allied health professional that supports nurses in assisting students and meeting administrative needs. They are trained in first aid, administration of medicine, case management, data management, use of the immunization compliance portal, and telehealth equipment and protocols. If a student in any of the 4 schools has medical needs that require the expertise of a nurse or an on-site service, the nurse will travel to that school to provide that service. In addition to direct staffing of school health suites who are part of the school health services program, the program is also comprised of telehealth services, care coordination and school integration services, training, and technical assistance and support. Telehealth involves the direct connection of students with licensed local healthcare providers, leading to decreased out-of-school time among students and eliminating the need for parents or guardians to take time off from work. Care coordination and school integration involves the use of case managers and health navigators to provide support for all schools and families through the provision of outreach, education, and family engagement. Through care coordination, linkages are made to ensure continuity of care, both in school and out of school. The program coordinates and implements all training programs relevant to school health services, including the administration of medication training for school staff, skills checks and professional development for health suite staff, and support for health suite operations. The district has now completed the first half of the school year under the new model. And while there have been challenges, we still strongly believe that using a team-based approach to staffing is the right approach and provides a more consistent and dedicated presence of health professionals in the schools. The start of this year had the highest recorded school health suite staffing coverage in DC Health's records, with 90% of school health suites having an in-person full-time health staff member. At the recent community event held by school nurses, one school nurse spoke on the start of the school year and how the new model, when staffed at this high level, worked far better than in the past. That is the model's goal, to foster and support a passionate and coordinated health team that can support all public school students and serve as a resource for families and school staff. However, since the start of the school year, new challenges have come to the surface. Our grantee and partner in this work, Children's School Services, saw a reduction in staff exacerbated by new challenges as the LPN and RN unions were negotiating their contracted children's. At the same time, several new health suites were approved, with necessitated pulling staff from other schools to ensure that the minimum 12 to 34 hours a week of in-person coverage happen there. Both DC Health and Children's are committed to providing the highest quality healthcare team in schools. However, these challenges had led to a significant decrease in staff, resulting in a drop to 52% full-time in-person staffing during the week of December 11th. As these challenges arose, DC Health and Children's School Services met regularly to identify solutions and update school staffing. As the staffing numbers declined in early November, DC Health and CSS adjusted schedules to ensure that schools with the most medically fragile students continued to have full-time coverage. Children's School Services also ensured that every school had access to AOM trained staff and telephonic coverage by nurse managers for any questions, concerns, or medical issues. By the end of December, Children's had resolved its contract with nurses with both LPNs and RN unions, leading to increased pay for employees. Furthermore, they re-engaged their recruiters, including a new recruiter focused on health technician hiring, to onboard dozens of additional staff members this month. Once the new staff finish their onboarding in early February, the coverage of school suites should be near full-time in all schools, and we plan to keep you updated monthly so you can feel confident that DC Health and Children's are committed to ensuring robust healthcare teams are available. We also are bringing our High Need Healthcare Career Scholarship Program online this fiscal year with an aim to train 200 new nursing assistive personnel, individuals who may augment the school health workforce as health technicians. The combination of these short-term and long-term solutions will ensure that our public school students' health needs are supported in school. We're hopeful that the end of the school year will end as strongly as the school year began, and the growing pains of implementation will disappear in the new school year. We believe that this is the only path in the decades-long nursing shortage to ensure all public school children have access to adequate health services and support within the school building. We hope you will continue to support this model, as the only alternative would be to return to past decades plus nurse-only services that leave many of our students and schools unsupported. I want to thank the council for hosting DC Health and Children's School Services to continue to raise awareness on the role of school health services in play in keeping our children healthy and able to succeed. I also want to thank the public witnesses for bringing their stories. I think it's important that we hear how the implementation is going whenever we attempt something new, and I'm available to answer any questions as needed.
Thank you, Dr. Bennett. Dr. Beers?
Good morning, Chairperson Henderson and the members of the committee. Thank you for being here. My name is Dr. Nathaniel Beers, and I am the Executive Vice President of Community Population at Children's National Hospital, and will testify on behalf of Children's National and CSS together. Children's National is committed to continuing to improve health outcomes for all students in every ward, and as Dr. Bennett noted, continues to believe that this is the best model to allow us to address the health inequities that exist in this city, as well as ensuring better coverage than we've ever been able to provide under the previous models. We thank you for the opportunity to talk about this testimony and to talk about this program, as well as the progress that we've been able to make. We also thank you, Councilmember Henderson, for your ongoing support to make sure that we are focused on improving student health outcomes and convening this roundtable. And I reiterate Director Bennett's comments on the appreciation that we have for the public witnesses, because it is important for us to continue to get the feedback on how the program is going. Children's National also deeply appreciates Council's approval of the additional $2 million in funding last budget cycle to Children's School Services for the fiscal 24 budget. Since Children's School Services came before the committee to discuss the budget and staffing needs in April 23, Children's School Services continues to partner with DC Health to provide coverage for health suites, despite the consistent funding challenges that have existed over the past several years. As we mentioned in our previous budget oversight testimony, Children's School Services has recognized that we needed to better align staff to support the needs of students and families. And in the spring of 2022, we presented a proposal to DC Health that would allow us to reduce the dependency on agency staff and ensure that we had a more consistent structure across the entire district. This school year, Children's School Services launched the new staffing model using the team-based approach mentioned by Dr. Bennett. This model groups schools within the geographic proximity into clusters of 4 and assigns dedicated staff that includes when fully staffed, 2 nurses and 3 health technicians. With this model, the nurses in the cluster provide clinical oversight for the care of medically fragile students, and the health technicians support the nurses in documentation, medication administration, first aid, hearing and vision screening, as well as serving as the immunization point of contact for schools. Additionally, this model is important to refocus the resources where they are most needed based on the health inequities in DC. While we understand the shift from the traditional school nursing model to a team-based model brings some initial concerns from parents and school leaders, it is important for the council to understand that this model is effective where provided with adequate funding to fully staff the program and in conjunction with the other components of the school health services program, such as care coordination and telehealth. The clusters with fully staffed model have staff and schools who have seen the value of having the model in place. Children's School Services has enlisted resources to recruit and hire talent, including working with nurse staffing agencies, conducting market survey on compensation in coordination with the Children's National HR, and most recently finalizing the contract with a health recruitment firm to exclusively focus on the recruitment of health technicians. Children's School Services has made a number of adjustments to address the staffing gaps beyond the recruitment challenges mentioned. During the summer, we onboarded a number of new health technicians. However, we were unable to recruit as many as we had hoped due to the clinical gaps in staff from OSCE workforce in schools. In addition, we did lose some nurses this summer to Prince George's County, as mentioned before, due to a change in compensation in the Prince George's County model. We have increased our retention capacity of the nurses by executing new collective bargaining agreements with both the RN and LPN unions this past month. Our current focus is to hire 60 additional health technicians to ensure that we have a person in every health suite. Since mid-December, we have identified over 50 new health technician candidates, and we are working diligently to vet those candidates and get those qualified candidates in schools as quickly and safely as possible. We recognize that we still have some work to do, but we are determined to be a fully staffed model. Since implementing this staff model, Children's School Services continue to work with DC Health to provide coverage of the health suites. However, Children's National continues to experience significant funding challenges with the school health services program budget due to overall budget reductions year to year. This has made it extremely difficult to maintain the full scope of services, compete with talent among neighboring jurisdictions, and to recruit and retain adequate staff. We developed the staffing model based on a fully funded budget of $28 million. For this fiscal year, the program was funded at $25.6 million, which only allows us to provide in-person health suite coverage and some case management support. The current budget does not provide resources necessary to implement the telehealth program as previously discussed. However, we continue to work with DC Health to ensure that that program can continue to be viable. As we look forward to the next fiscal year, we believe it is critical to fully fund the school health service program to ensure we can adequately address the health needs in schools and be part of solving the health inequities of DC. Children's National is committed to providing school health services through a comprehensive school health approach that can address health equity, ensure adequate staffing, and assure that we are providing for the additional health needs that exist in schools, including school attendance and chronic disease management. While we are proud to partner with DC Health to staff and implement the program, it is critical that the district sufficiently fund this program to meet the needs of students. As the committee prepares for the FY25 budget cycle, please consider that continued commitment to addressing the health needs of students and schools can result in real improvements in health outcomes. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you to all of you for your testimony. We'll do 10-minute rounds. And let's see if we can get through it. All right. I want to ask some follow-up questions about some of the testimony that was raised. So Dr. Beers, I'll start with you. You know, Dr. Boudreau, you were here for the hearing we had last year. Yeah. Welcome 2024. So last year, and we talked about staffing. We talked about what the recruitment was going to look like for the health tech positions, et cetera. And then Dr. Beers, you have a line in your statement that says, However, or it says, during the summer, we onboarded a number of new health technicians. However, we were unable to recruit as many as we hoped due to clinical gaps in the staff from OSSI workforce in schools. What does that mean?
It means that there are about 500 OSSI-based staff who had been in schools during the school year 22-23 school year. And we expected to be able to recruit a substantial number of those staff into the roles. But as we looked at their clinical skills, they did not meet the minimum requirements that we had to be able to consider them for employment. And so we had to expand out to other sources for additional staffing.
Okay, so to further break that down for people who haven't been or weren't paying attention to the last 2 years, that OSSI workforce, I'm assuming you're talking about the individuals who are hired for isolation rooms and temperature checks and other things.
Correct.
Okay, so how are we recruiting now?
So as I noted, we've reactivated once we resolved the budget issues in December, mid-December, to re-engage. In the first week of re-engagement, we identified 15 potential candidates. And over the course of the first 3 weeks since we've re-engaged with recruitment, we've identified over 50 potential candidates for those 60 spots that we need to fill.
Okay. Are we recruiting specifically with some of our adult public charter schools who have these CNA, EMT programs like Academy of Hope, for instance? They have graduates churning out of their programs who are coming out with certifications.
I'm going to defer to Dr. Boudreau on that one.
Thank you, Councilmember Henderson. We do not go to the graduates because we do require 2 years of experience.
I see.
So the new graduates are not, but they are a great pipeline for future roles, but they're not good for initial roles.
That's fair. I will say this, most of these, in the same way that you and I are alumni of institution and we receive emails about jobs, letting them know that these are available to go out to their networks, I think is another incredible way to do that.
We have engaged the Seating Disruption Network to support, to share some of the opportunities. So we are partnering with the education team across the district.
Okay.
But we can pursue the adult education and make sure that we've got adequate reach out to their alumni communities so that we're broadening the net in that space as well.
Or use us. I do PSAs every hearing about if you're interested in serving on a board, so I could do a PSA around if you're interested in serving in our schools, that we can also provide that information as well. But let's get down to a little bit. So just for clarification, you mentioned in your testimony, you resolved the contract with LPNs and RNs. Are the LPNs and RNs under CSS considered in the bargaining unit for Children's Hospital?
No. We are separately incorporated CSS, and so it's a separate bargaining unit from the hospital.
Okay, so when you talk about the contract negotiations, it was specifically
for CSS.
For CSS. Okay.
Yes.
Well, let's go a little bit deeper. Dr. Beers, you mentioned in your testimony that Prince George's County changes compensation for nurses, which led to some challenges of retention. And I mentioned during the public witness testimony, this is a dog eat dog world. We got to fight and compete. So what changes happened in PG that we need to do better at matching on our side?
I think go ahead. I'll say there's two things, right, that we need to look at. And we've been in conversations with Robin, right? One is the overall compensation. We've solved that issue, right, with our new contract that we've executed.
How much we paying? Okay, what's our range?
Our range is $48 to $61 an hour.
Okay.
Okay.
That's for RNs and LPNs?
For RNs.
RNs.
I don't have the LPN on the top of my.
Okay.
But it is equivalent to Prince George's County. The second issue is an issue that Prince George's County is a 10-month year. We're a 12-month year. And we need to think about, because we have more substantive 12-month coverage, partly because of our charter school schedule, as well as the number of schools that have summer schools is different than most school jurisdictions. So that is why there is a differential that we have to consider how we think about some more 10-month opportunities.
Well, that's what I was saying. All of our schools are not 12 months. So there could be a portion that you're offering.
We already have a portion. We have to look at the adjustment as to whether or not it's enough.
Okay. How much should we pay our health techs? Well, give me the range.
We will have to get that for you.
The current range is 19 to 25 an hour.
Okay. Okay, that's not, I mean, it's not bad. Just for folks. I went on Indeed. So, Anne Arundel County, we gotta go out to our suburb friends. They pay 41 an hour. I have PG County paying 52 an hour. So for the RN positions, is that incorrect?
I think that's probably the average salary. I don't think that that's the starting salary,
Okay.
but we can get that data and make sure that we're aligned in that space. We are doing a market analysis as well to make sure that our starting salaries are comparable. And so that is underway as well.
Okay. Will that market study analysis be complete before the budget process for next school year?
We can make sure it is.
Because
Yes.
you give me the market analysis in July, that is
It
unhelpful.
doesn't help. I understand.
Okay.
We know your timeline.
Yeah. Okay. So when you talk to colleagues in Maryland and Virginia, Dr. Bennett, are they experiencing the same challenges that we are? Your mic's not on.
I throw the net a little wider than that. And just when we talk to state health officers across the board, school nurses fall into the rest of the medical community. We are having a nursing challenge at every level of care, more than we had before, and it was bad before. So when we are talking about setting priority around where we send our not sufficient number of nurses, we are talking about them going between hospitals and schools, but also all of our FQHCs, all of our hospice sites, all of our long-term care nurses. We use nurses in a lot of capacities, some of them with incredibly fragile people.
Mm-hmm.
And we need to be judicious and efficient about where they are and what we use them for. We do not have enough to cover all of the needs. They just simply don't exist. And the ones that we have, we are losing some.
Right. So let me ask you then how we do the algorithm of who gets what within the availability of personnel that we currently have. I'm hearing more and more situations where a school has a child who is enrolled who has an asthma plan on file or has some medically fragile condition, and yet you all didn't know. So your staffing model or your staffing distribution doesn't reflect the actual needs that are happening in a school. The same, I could ask the question of, we started a new school year. There are probably 10 to 15 DCPS schools that received new children at the start of the semester. So how often do we check to make sure our staffing allocation is still appropriate for the populations of students in that building?
We provide an updated staffing schedule on a bi-weekly basis.
You got to speak up just a hair a bit.
We provide an updated staffing schedule on a bi-weekly basis. So we're constantly monitoring when new students are coming in. We also meet with the schools when we are made aware of a new student with medical needs so that we can attend the 504 meeting.
Okay, so who tells you all, whose responsibility is it to alert you that there's a new student with a new medical need?
The school does.
Okay, so the principal?
It depends. We work, Ms. Harris, who we heard from today, we work very closely with her for friendship. We work with the central office with DCPS. The different LEAs have different representatives who reach out to us to alert us.
Okay, Dr. Bennett, to what extent are all the LEAs informed about the protocol?
I am going to defer to Robin Diggs-Purdue, who's my senior deputy director over this program.
Yeah, we consistently do education with our ed sector partners and the LEAs around the process. But that is an area that we do want to consistently improve on as well and make sure that is efficient. You mentioned electronic records, right, versus paper. That is something that we've been consistently working on over the past couple of years with the UHCs, and we're working on it with the asthma action plans, and it applies to this type of scenario too. It will just take time.
Okay, I'm gonna come back to that. I'm over my time. Councilmember Freeman.
Thank you very much. I'm going to stay on this, the algorithm question and the mid-year arrivals, because it strikes me. I mean, it has always been the case that DCPS sees 500 kids, a net growth of 500 kids each year. In recent years, that's been more like 1,400. And so the landscape changes relatively dramatically during the year. And I've also heard, a school where a child with, I'm not medical, but type 2 diabetes, something that was high risk and didn't have a nurse assigned there, and wondered about how the algorithm worked. So can you speak to how the algorithm deciding which schools get nurses operates, how it's adjusted during the course of the year? And then one of the things about the new arrivals is, frankly, many of them come from Latin America and may not speak English. How does language ability work into how you're assigning nurses in different schools?
So thank you for the question. So first, we base the nurse on medically fragile children, and that's nursing required training to provide the care that they need. So those are things like G-tube feedings, catheterizations, tracheotomies. Those require a nurse. A health technician could not do those. So any school that has a student that has one of those, a student with any of those treatment needs would have a nurse assigned to them. Outside of that, so things like asthma, which we know we have a large population of students with asthma in the district. Type 1 diabetes is also something that we're seeing growing in the district. Those do not require a nurse. We do train our health technicians as well as the AOM staff to be able to treat students. They're also trained to understand the signs and symptoms of things like anaphylaxis, so that when a child presents in the health suite with a medical emergency, the health technicians are prepared to treat them and administer medication through the AOM program that is funded also by this program. You mentioned we also in this fully staffed model, that cluster nurse, the responsibility of the cluster nurse is to go about and to understand some of those social determinants. That's what we were most excited about, was having someone who could really lean into the social needs that the children in the schools had and understand some of those things like food insecurity, transportation issues. Our care coordination and our cluster nurses, our care coordination team and our cluster nurses are critical in addressing those issues that have been also raised inside of the health suite. When we make those adjustments based on children coming in, we had a new student that we're just having a 504 for that joined one of the DCPS schools with significant medical needs in the end of October. We had their 504 because we were waiting on documentation from the physician, but this is constant throughout the year. So we continue to assess and evaluate based on the enrollment that changes.
All right, thank you very much for that. I mean, the way you described it, it sounds like a nurse in the cluster would be looking at conditions at all of the schools in the cluster and be in a position to go deeper. And maybe this goes to one of the other things that came up. I mean, it's been reported that the RNs went from 60 at the beginning of the year to 40, and the LPNs from 40 to 20. So we lost, according to those reports, we lost 50 or 1/3 of the people the nurses that we had. And one question is why? And there's some things in there about wages and some instability that's going on. But then there was also testimony that to some extent, it's this change in conditions and instability about the conditions. And I wonder, it sounds like, in a way, a new, heavier responsibility. You're not just the nurse at one school, you're the nurse at one school with supervisory responsibility over 3 other people, maybe, and a mandate to be an emissary trying to figure out the conditions at all of the schools. So to what extent Does that kind of changed responsibility, instability, could that be contributing to the erosion that we've seen since the beginning of the year? And Director Smith, I see you going for it. I'd love to hear an answer from both of you.
I just want to level set us for a moment. The job that we are outlining of a nurse doing skilled procedures and supervising trained but lower skilled staff is the standard for nurses across the industry. Having a nursing job where she had no supervisory responsibility and also took care of only or mostly low acuity patients is a disappearing entity. And I don't want to advocate that we be the last purveyor of this disappearing entity. I don't know that it is efficient use of our time, a good use of nurse training. A skill that you use only every once in a while is a skill that you will lose in medicine. So if you do something not very often, you are not very good at it very soon. That is just a principle of medical training. And so having nurses work at the top of their scope is the same thing that's happening in the clinic that you likely go to, in all of our hospitals. That is where we are moving. So needing to supervise lower skilled staff who can do things that you can do, but can't do things that you can do, is the way in which medicine and assignments are given. And it is absolutely where nurses are at the moment. So that would be a job that they're not finding somewhere else necessarily. Even in the counties where they are competing with us for salary, most of those have a team-based model also.
I mean, that's super useful actually, because I think it's a candid acknowledgement of a culture change. And we're hearing about that culture change in a different way, because one of the things that was referenced is a school nurse position might not be as well compensated as other nurse positions, but it's, and we heard people say this, but it's different. It's less hectic in a certain way. But what you're saying is the school nurse position is evolving to be more like nurse positions in other settings, and that you see that as an inevitable transformation. It may be that then it needs, if that were the case, that needs to be acknowledged, that school nurse compensation shouldn't be so much lower, or shouldn't be lower than other kinds of nurse compensation, because the role is getting closer to what that role might be.
So a couple things just to clarify, just for one, that school nurse compensation is comparable to other ambulatory nurses compensation, right? So while there is a differential that exists for inpatient hospital nursing, that is really a very different job with a different level of acuity of care, and there will always be, in the same way that in the physician workforce, there's a differential that exists between ambulatory physician work and inpatient physician work, particularly as you go more intense, the salary tends to be consistently increasing in that space. The second piece that I would note that it is important to clarify when we're going to talk about the actual numbers, which is that between the RNs and the LPNs across children's school services since July 1st, there have only been 25 nurse resignations. So this number that DCNA has been putting out, about 30% of the RNs or 50% of the LPNs, is not actually borne out by the actual evidence of how many nurses have been lost. It doesn't mean that we don't need to look at each one of those and be really critical about why are they leaving, and are there things from a systematic perspective that we should be thinking about doing differently. But it is important, as Dr. Bennett and I both noted, to understand that those nurses who are in the fully staffed model actually think that this is a model that makes sense to them and is a rewarding place to work. We're not fully staffed, and so we acknowledge that it's a hard transition, but we've got to give ourselves the chance to get there before we sort of take judgment to say we have to go back to the RN in every school model, because the reality is we will be way below 40% of full-time coverage in every school if we return to a nurse model.
Okay, I'm out of time.
But do you want to follow up on this point specifically?
No, I'm okay.
Okay, all right. I want to give you an opportunity to fully realize that point. Councilmember Parker?
Thank you all for your testimony. I will start by simply saying I'm of the mindset that every student in school does deserve a certified registered nurse, and have been skeptical of this approach. I hear you loud and clear, Dr. Bennett, when you're saying this approach, although not perfect, is our best way of getting coverage for the number of schools that we have here in the district. So I just want to level set there. You mentioned that the nursing shortage in DC, Dr. Bennett, is decades long. What analysis, if any, has DC Health done on the drivers of that shortage?
I can say that the staff whose job that is not in this room.
Okay.
But that is the impetus for the loan repayment. It's a lot of the programs we have are in response to that shortage. The drivers of the shortage are not, I think, particularly different across environments. There has been in recent years an attrition from nursing altogether. So people who are burned out have moved on to other careers or resigned and retire early, or any number of things. We're in a post-pandemic effect. Before that, we had really limitations on nursing education and whether or not people were able to get nursing education. We had expansions in medical care. So as we get more and more intensive inpatient and other kinds of care that do require nurses, they are lost in other parts of the system because we just did not keep up in terms of educating. It's in many ways the same as our primary care physician population. We just have not trained and deployed in a way that keeps up with the increasing need.
Gotcha. You mentioned in your testimony that the aim is for schools to have 24 or 32 hours of coverage a week, or that schools have 24 or 30?
It was that's a minimum. So when we it was that there not be somebody with less than that.
So 24
we want 40.
or 32 hours. We want 40. How are you determining the schools that get 24 versus 32 hours?
I'm going to let children say that, but I just want to clarify that we were in a fully staffed environment, and then we were in triage, which is not necessarily the way the program is going to operate. It's what do we have to do now that we don't have enough for everybody? How do we now start to prioritize and move people? So that is a triage response, but we can discuss how that was done.
Gotcha.
So at the beginning of the school year, Councilmember
It's
Parker,
good to see you again.
At the beginning of the school year, we based our information on last year's medical information. So we had to receive the school health forms from the school. So we staffed based on the information we had from the previous year. As we received documents from the schools and from the families, we were able to adjust. And so we saw a number of staff school schedules. We submit a school schedule by ward. We saw a number of changes to that as we received more documentation from the schools.
And am I to assume that the severity of health needs at that school influences whether you have 24 hours of coverage versus 32 or ideally 40 hours?
100%.
Got it.
It also determines, it also determines if there's an RN, an LPN, or a health technician assigned to the school.
I was going to go there next. How many RNs do we actually have?
We have 45 employed RNs at this point at the end of December, and 15 agency RNs. We have 36 LPNs who are employed, 4 agency LPNs, and 62 health technicians.
And those 15 agency RNs, is that included in the 45 RN number?
No,
so that's an addition to.
Yes.
Got it. and then you said 62 health technicians.
Correct.
And while I have you all at Children's, I know you all are ramping up with the health technicians, and you talked about you have, I recall 50 people in the pipeline, I believe you mentioned.
Over 50.
Over 50. What is the number you're trying to hit?
60.
You have 62 now.
We need an additional 60.
You need an additional 60. Got it.
So
All
we
right.
have 50, over 50 of the 60 positions.
So if you were to hire an additional 60, that means every school would have 40 hours of coverage?
Correct.
Got it. And are we looking to hire any more RNs, or are we just focused on the health technicians?
We are looking to make sure that we have employed RNs because they're cheaper. So we are always looking to hire more RNs. We would like to have 55 RNs and 45 LPNs in place as all employed in a fully staffed model, and then 122 health technicians.
Got it. Okay. That is super helpful. Dr. Bennett, coming back to you just on some, I want to level set. When you say 90% of health suites have a full-time staff person, am I in your testimony? Had. Okay.
Had at the beginning of the school year. So we
it's the beginning of this school year.
Yes, we started nearly fully staffed and then had attrition. So especially at the end of October, there was a.
But I just want to level set. So when you say 90% of health suites or our schools had a full-time staff person, am I to understand that that is at 40 hours? Is that at 24
that's what
hours?
full-time means in this case. We mean 40 hours.
And now we're down to 56. Is that accurate? 56%.
It's a
50. It's 52.
52%.
Yes.
Got it. Okay. And then one word, Dr. Bennett, with the new administration requirements coming from this committee, for instance, the administration of glucagon, among other things, how is DC Health coordinating with children, schools, and others to just ensure schools are adhering to new policies coming down the pipeline, given the shortages that we're addressing?
So part of the program, which is not about the staffing, is about training and making sure that medication administration training happens at schools. So that is not dependent on the full-time staff member. That's a separate part of the program. So those medications would be included in that. And those require training because just like I think was discussed, if you give one of those medications, you should be calling an ambulance at the same time. They are not meant to be curative. They are meant to be supportive until you can get to a higher level of care. So they require training.
And what I'm getting at is to what it, because I recall the back and forth about the protocols for schools that may have students with higher health needs. I agree with you that schools should be calling for greater assistance, but what does that training look like in practice, given some of the shortages? Because if an RN were on site, there would be someone there to give more guidance, knowing that some schools may be without that support. I'm just wondering how we're going about the training. Yes.
So the administration of medication is the fourth PID for this program. So we train both our health technicians and school staff on how to identify signs and symptoms, how to treat and administer medication, and how to know when to call for support.
And that training is ongoing, I'm assuming.
Absolutely. So it's a part of the health technician orientation. And then throughout the year, we provide AOM training for the school staff. So if a school, like when they go on field trips, so even when we are fully staffed, the school is still required to have AOMs because we do not travel on field trips. So the school staff still remains having AOM support. That gives them epinephrine, glucagon, albuterol, and then identifies the signs and symptoms for some of the more regularly experienced medical needs in the health suite.
I see my time is ticking. I'm gonna, while I have you, Dr. Boudreau, and Dr. Beers, I want to level set on the numbers. So the current funding is at 25.6 million. The top line number that you're requesting is 28 million for a fully funded program. at the same time, you're saying you're doing a market study. Are you anticipating that that $28 million figure will change?
I will be able to better answer you once we have that market analysis. We did include that the market changes that we've made for our nurses already in that analysis. So the question will be, is there any additional market need in the hiring side of things? And then the last piece that I will say, and we will partner with DC Health and continue to partner with them, is we need to make sure that we're prepared for additional schools, because part of the drop that happened in October was opening up new health suites meant we had to move staff from their current health suites to
That's
cover.
the elephant in the room.
Yes.
Yes.
So, you've been on the school board, you understand that reality. And so we need a process that makes it clear when that process has to be done, so that we can be prepared for the budget and so that we can be prepared from a staffing perspective.
So, and I'm over time, I'm going to wrap here, but what I'm hearing you say is the top line number right now is 28 million. That very well might change as a result of this market study. And I know you all are going to focus on trying to get us that information before the budget process. Okay. Thank you all.
Thanks, Councilmember Parker. In the market study, one thing I'm kind of interested in when we think about, we're also competing with FEMS for EMTs. So, right, like if I have an EMT certification, I could apply to work for FEMS. So I think we have to include the pool of other opportunities, at least on the health tech side of where things go. But I want to talk a little bit about the money. So in 2017, the grant for school services was 19 million. In 2023, it is 25 million, with the committee pushing, because originally DC Health had proposed cutting that by 4.5 million, which would have meant 6 years would have gone by and this grant would have increased by maybe $3 million in the given environment that we're in. When I talk to folks in the community, and we've heard obviously from several public witnesses today, they say, but I want a nurse in every school. And I say to them, the budget that is for this program would not deliver on that. Is that accurate? Could Children's do a full-time registered nurse with $25 million?
No.
Okay. How much would it cost?
Over $30 million.
And that is with the assumption that we don't add any more LEAs.
Correct.
At the same time. Okay.
Correct.
But what I'm hearing from you all still, Dr. Bennett, is that you don't believe that is a appropriate model for where we are.
I don't think it conforms with reality. I think wanting something and getting it are not the same thing. And that where the market stands, where the availability of nurses stands, and where we need nurses in our healthcare system, we should use staff who have adequate training to do what is most often needed during a school day, which is at the health tech level for many schools, when we are able to do that, because it prevents us from having gaps in service where there is no one except a teacher to pull who does. There is definitely a gap between the training of a health tech and an RN, but there is a gap between the training of a health tech and a teacher.
Yeah.
So these are not unskilled people, and they come with training and are given additional training and learn on the job. So it is not the same as going from an RN to nothing, which was the choice we were making before.
Okay.
It's an RN or nothing, and a lot of the time it was nothing. And going back to our way or the highway again is not probably going to result in a different arrangement.
Okay.
Yeah. I mean, if we look at just our nurse staffing, right, we did not get above 50% of the nurses that we needed in order to staff over the last several years, despite quite extensive both local and national searches to try and find nurses to come into this field. We also, to just be clear about the expectation of what the job is, we had a number of nurses over the past couple of years who thought this was their way to deal with burnout, right? You step away from ambulatory nursing or hospital nursing and you get to do this nice, easy job in a school. And they arrived in a school and realized that in fact, a nurse job in a school requires a lot of work. And knowing a large population of kids and being able to navigate all those spaces. And we had people who came and left quite quickly because they really weren't prepared for the job. And so even if we thought we had enough money, there is no way there are enough nurses in this region, but also more broadly across the country to fill the gap that would be required to get to 40 hours of nursing in every school.
Okay. So let's talk about how we do the cluster model or how we do the clusters. One of the things I remember asking your predecessor, Dr. Or Ms. Purdue, was around for charter schools where we have multiple schools on the same campus not being treated as one. And so it's a little alarming to hear public witness testimony that I have some public charter schools where there is an elementary school, a middle school, and a high school on the same campus that's being treated as one in the cluster. And then 4 additional schools or 5 additional schools are being added to that. What happened here?
So the unfortunate reality is if a charter school elects to put multiple health suites on that campus, we would staff. We have a number of we have other examples where there are 2 health suites on a campus. The LEA we heard from has 1 health suite, 3 principals. So they identify 3 leaders, but they have only dedicated 1 health suite for us to staff. So that is why they're seen as 1 health suite, because they have not produced 3 health suites for us to staff. They would be able to be in the pool for 3, just like other schools who have multiple health suites on their campus.
Okay. This is helpful clarification because I was like, we talked about that very specifically to make sure that that didn't happen. Because I'm not going to say we have a number of charter schools who are very similar situated in that regard. On that front, would it be helpful for us to have a deadline of your health suite has to be certified by X date in order for you to participate in school year X?
Yes. It should align with the budget season and it should align with the rest of our planning, because to have essentially a construction deadline, I suppose, set when we are obligated to increase staffing and to find money does not make sense. It's not the way we do the rest of government. And also if you're in a state where you are now, having you remain in that state until we can do things in a reasonable fashion seems safer than us trying to pull from all the other schools to try to figure out what to do with something that just happened in a kind of, we definitely approved the health suites. We knew they were coming, but we have not been controlling when they come, which I think is a mistake.
Okay. We could talk about that more. Obviously, we'll probably hear from the public charter school board who would say, our schedule of approving new schools doesn't align with the budget, which is its own conversation piece. But you know, if I have a charter school who's been approved, but they don't have a location set until June, and then they have to build out their suite, then we're essentially saying to them, you will go your first year in existence as a school without being part of the school health program.
Or we make some commitment early that you are planning it, you've made a commitment to it, we're going to staff it at. We just have to know and have some assurance of how to plan for things. At the moment, I don't think we're able to do that in our budget cycle in the way we would want to. But yes, they might not have staffing immediately. They won't have staffing immediately now because we're having to shift around. So wanting things to work on the school year schedule is not unreasonable, but it is also not very well aligned. So needing to push a little earlier in order to get the health suite to be part of your school is, I think, an expectation we're going to have to discuss.
Okay. Let's discuss that more. I want to ask a question that kind of raised from the public witness testimony around nurse coverage in the after school environment, particularly when you're doing programs like DC Scores and other things. How are we managing that this school year?
So our staff do not support anything outside of the school day.
Did they used to?
Never.
So that was out of the goodness of their heart that they stayed?
Correct. Our hours are 8 to 4:30. They are in the
Well,
building.
okay,
Mhm.
8 to 4:30, which
but they
means
do
you are technically after school.
They're in the building, but they do not support. So those programs that have the after-school care, at school activities, our nurses do not support those programs.
So if a child has an issue at 3:15, the
The
nurse is there, but the nurse can't do anything?
the current practice is that EMS is contacted because the nurse work we don't have documentation. Some of those programs have students coming from other schools, so we don't have documentation. So our current practice is that the nurse does not support after school because we don't have medical records on everyone in those programs. Mhm. If an emergency were to arise, none of our nurses would say, oh, I see this child hurting, so I'm going to let this child sit and be injured. None of our nurses would do that. We do not actively support. So we're not at practices. We're not the provider. We're not required to be there. I may call a staff meeting at 3:30. So the nurse is not engaged. We limit our staff meetings to after the students are gone so that the nurse can pay attention in the staff meeting. So
Okay.
if there's an emergency, none of our nurses would watch a child be in an emergency. But the
Right.
nurses,
I'm sort of thinking now about, we got a litany of after school programming and activity that happens, a lot of it active in nature.
Mhm.
I know for high school teams, if it's a football game or a basketball game, you are required to have personnel there who can do that.
Mhm.
For elementary schools, I don't think we require that. Is this a gap?
Well, my understanding is that all of the coaches are required to have first aid training.
First aid is not AOM.
I understand. And we did talk about whether or not we could open the AOM training to those coaches as well, who wanted to become certified in AOM training. And so certainly we can work with DC Health to make that possible if that is something that schools are looking for.
AOM training is part of the 25 million.
Yes.
Is that enough?
To do it.
I think it's kind of crazy to me that a PTA is going to fundraise in order to do a Red Cross training on AOM. No shade to the Red Cross, but I would prefer,
Yes,
as would we,
that they like have the actual training.
Mhm.
But I'm assuming the budget for AOM is based on our guidelines and laws around the number of individuals in a building who needs it, not now adding coaches onto it. That's an additional cost, yes?
Yes, and we're also working through some changes with the emergency medication plan that we're working on, where we may restructure how some of that AOM training is done. And DC Health has more of a leadership or coordination role of some of that training. There's online platforms that can be used, especially to support the EpiPen training, as well as the training for albuterol. So there's options that we're exploring that may not cut into the CSS budget, and it would allow us to open up and manage training for additional staff in the school as well as coaches and others, in addition to the minimum requirements that we have for some of those medications.
Okay, I'm over my time. This is another area of exploration because I have to, I know what the runs data for FIMS looks like, right? Even on just other stuff that's not related to schools. I can ask the chief on the numbers of schools. I'd imagine though, the chief is very direct. So if there was an issue, he would come to you, Director Bennett, and say, hey, what's going on? Because I'm at this school 10 times in a week. They need somebody or whatever. But now I'm sort of thinking, okay, if the coverage technically ends at 3:15, even though somebody's in the building, then we have a litany of after school activity that's happening where is YOLO. Good luck. And I think for as a parent, that's like, what are we doing?
So I will say, I can say no one on my staff would watch a child be injured or hurt and not respond. What we encourage the schools to do, though, is to find, so I'll give an example of a school that has children coming from multiple campuses. So for the nurse to be able to treat something, he or she has to be able to document on what they're doing. So if a student is coming, I'll use Roosevelt, Dorothy Height. We know that those are two different grade levels. But if a student is coming across the street for an after-school program and I have no documentation, a method to document on them, no way to see them in my system, that's where there's a problem. So historically, our staff has not been a part of after school or before school care. We heard earlier about students coming in at 7:30. Our staff is not in the building at that time. So if a staff member is there and sees a child in need, I have 100% confidence that they would support that child and we navigate that. But the system is for them to not provide services outside of the school day.
I'm over my time. Marcia, can you give Councilmember Freeman and Councilmember Parker 13 minutes? Great, thank you. This will be likely the last round, so make it count.
All right, thank you very much. So I was looking at one of the presentations and it says that DC Health Services provides care for 80,000 students attending DCPS and public charter schools, 117 DCPS health suites and 63 public charter school health suites. When I look online, I think there's 135. I assume the 117 is all the DCPS schools. I think there's 135 charter schools. So is it that those 63 health suites serve a total of 135 schools, or are there schools that are not in the program because 80 is lower? There's 20,000 kids who are missing. So
that's correct. There are charter schools who do not participate in the school health services program.
What do they do?
Some contract their own nurse, and we have in that AOM training that we discussed, we do provide AOM training for schools who do not have a school health services program nurse. In every class, we allot seats for those schools so we can at least provide them with AOM support.
Okay, terrific. One of the things that was raised about the cluster model is, for example, the Jackson Reed cluster, which has close to 4,000 students. How does the number of students there's geography, but then there's the number of students, and at some point you have so many students that it would seem like there probably would be a need for additional staff. But how does the number of students figure into assignments in a cluster model or creation of a cluster?
I was very fortunate to be able to meet with the Ward 3 Education Network in the late spring. And we talked about this very thing. We initially had Jackson, Reed, and Deal as a cluster by themselves. And the parents said loud and clear, you cannot do that. That is just too much on any cluster. That was just too much. What we know, though, we'll go back to the social determinants. It's if children in the building are healthy. And so what I presented to them was the number of students who had medical needs in the school. So yes, any child, stellar athlete, can fall down the stairs, break a leg. We need someone there. The reality is we did not have enough nursing support to be able to staff because of what may happen. There are a number of children in the district who require G-tube feedings, who require catheters, and who require trachs throughout the day. So we had to prioritize nursing staff at those schools that had medical needs, not necessarily about the volume. The health technicians are there to support. That's why we transitioned the model. When we first came before you, we only wanted 4 people per cluster. That's where there's some variance in some of the literature that you saw in the very beginning of our proposal. We moved it to 5 because we said there's going to need to be some movement, and we didn't want any school to be without staff. So when there's an emergency, the nurse can move and not leave a school open to support if something happens while the health technician is there. The health technicians are also wonderful at being able to support some of the documentation and ensuring that the cluster needs are met. If we were to try and staff based on volume, there would be nurses who are not, as Director Bennett said, not practicing at the top of their scope. To have nurses in a school because there's a large number of students was not the most efficient use of the limited resources that we have.
So then the cluster model is an LPN, an RN, and 3 health techs.
That's the ideal staffing.
That's, yeah.
Mm-hmm. Now, another thing I'll clarify, we did not want to lay anyone off. So we had more RNs than we had clusters. So the district is broken into 46 clusters right now. And we had more RNs at the start of the year. Between agency and hired. So we didn't want to lay off any nurses, right? No one wanted to see one nurse lost. So we have a number of RNs who are considered treatment nurses who act as the LPN. So they're in a school that has treatment needs. And so while there's the cluster RN that does the movement, there are a number of schools that have an RN assigned to them that does the treatments because we had more RNs than we had LPNs.
So is a typical thing that if there's 4 schools in a cluster, that there would be 2 schools that had a health tech, 1 school that had an LPN, 1 school that had an RN, and then you'd have another health tech. Would that person generally be where the RN is because the RN moves around?
That's correct.
Okay. One of the things that it sounds like you're getting closer to where you want to be in terms of hiring. But I was struck by the reference to the adult public charter schools and the fact that there's an existing pipeline for that of people who could work in this area. You have the 2-year experience requirement. Any thought to apprenticeship programs? Any thought to having folks in the schools, adding to the number of adults in the schools, but themselves, in a sense, getting training?
Yeah, it's a great question. We actually, Children's National has been working closely with OSSI around their new advanced training center and thinking about how that can create the pipeline that Dr. Bennett was talking about. And so a part of that is creating an apprenticeship program. We are looking to, we have proposed to place a clinical site on site at the Advanced Training Center at the Penn Center that would allow on-site opportunities. But they have been working closely with all of the hospitals in the DC Hospital Association to provide apprenticeship program. Certainly Children's National has been very engaged in that, in thinking about how we could create opportunities. There's a little bit of a delicate balance of having a high school student work in a high school, taking care of other high school students. So we do need to sort of navigate some of those complexities and patient confidentiality and all of those components. But there are over 100 students currently in that nursing health career program. And we look forward to recruiting them, because the reality is the way we're going to solve this problem is by creating our own pipeline. Health technicians are the start of that pipeline. What we know at Children's National is that when we create a pipeline in our home health agencies to have home health aides, who then becomes LPNs, who then become RNs, we do a better job of maintaining our workforce because they're local, they want to stay local, they know DC, they love DC, they want to be with their families. And so that's the way we're going to solve our long-term crisis, is making sure that those CNAs or PCTs or EMTs see a long-term trajectory, Now, the one thing, and we have met with healthcare finance about this, that we have a problem locally in, is there is not great LPN training opportunities. And so most people are right now doing the jump from nurse assistant straight to RN. And we have a very poor pool of LPNs. It's why we struggle with recruiting them more than RNs, and why we have more RNs than we necessarily need for the model, because we need to make sure we have enough nurses to make that model work.
Okay, well, that segues nicely into another area that I was going to ask about, which was Director Smith, you talked about, made a reference to the high needs scholarship as part of the pipeline, and I'd be curious to hear about that. But also State Board Member Goulet talked about pipeline issues, possibilities, for example, at UDC. So I wonder if you can talk about that scholarship opportunity, talk about, both of you, all of you, talk about how we can strengthen the pipeline, including for LPNs. And for me, I'm particularly committed to trying to strengthen UDC, how UDC might be able to fit into that picture.
I'm going to let Robin key in if she has some additional information. So this was an idea from our health licensing staff who were participating in these discussions about how to solve this problem. The scholarship program is more broadly for health careers, but it does include the level of staff that we would talk about for health tech, which is not a single thing. It's a whole scope of practice. So that is coming online next year. So I need more time to get the rest of the detail because I don't think it's quite baked, but we do plan to try to attach that to this program. They would need to get experience, but we can work on how that would align.
Children's also offers tuition reimbursement. And so the staff have access if they're going to move from health technician to RN or we've had a few of our staff have left the district to go off to nursing school. We do our best to bring them back. We have some bridge of service in their collective bargaining agreement to bring them back once they complete that training for both LPNs and RNs. So we do work to bring them back and allow them to maintain their seniority when they come back so that if they go off to better their education, there's a way for them to come back.
Then on this issue of a gap in training for LPNs, can you just speak to that more and ways in which that gap might be able to be filled?
So I think there are currently no LPN training programs in the district. That is the gap. Certainly UDC could be part of that solution. There have been a lot of conversations with Trinity as well about where they fit into that process as well. I think that it certainly could help create some long-term career trajectory for people who are choosing to leave the area to get trained because there's no training program that can support them. And so again, which causing them to jump often straight to an RN program, which certainly has a lot more financial benefits for them, but certainly also has financial costs associated with it and often requires that they take time off of work in order to complete that program, given the clinical requirements. And it is more common for someone to be able to complete an LPN training program while they are carrying on ongoing work, given the way the program is structured.
Wonderful. So I didn't think I was going to take my whole 13 minutes, but it turns out I am. One of the things that you heard in the testimony, and I imagine you found it distressing, the folks at Friendship Public Charter School who were so dissatisfied with some of the people who had been on site with them. And how do you deal with those kinds of issues? I mean, you spoke to it a little when you said, you know, people who had one expectation about the job and it was different and then they didn't stay. But how much of a challenge is this and how do you deal with it when it arises?
Yeah, so let me give you a level setting and Dr. Boudreau can give you more specific detail if you want to go there. All of the nurses and staff were provided the opportunities to rank where they wanted to go. And then based on seniority, nurses were moved where we needed nurses. None of the nurses who were placed at Friendship schools chose to rank Friendship schools as the places they wanted to stay. So there's a reflection that we need to do on ourselves for sure as CSS, but we need our education partners to also understand the environment that they are creating for our staff and what the experience and partnership is and how they are treated if they're expecting to retain staff.
Okay. On that, I'm over time. Thank you.
Thank you, Councilmember Freeman. Councilmember Parker.
Thank you. And Dr. Beers, I appreciate someone that just talks pretty directly. There are a few areas I want to hone in on, and I want to end on solutions. And so outside of money, I hear clearly there needs to be more money, but what are the solutions needed from the council and or other city partners to make sure this program is successful? I'm going to end there, but there are a few questions. The first is around coordination. One need I'm hearing is coordination with the charter board as they are onboarding new schools. I agree there should be a date or a deadline set for new health suites. And I think there is a way that the charter board can incorporate a request for new health suites in their approval process for new charters. And so I'm happy to play a role in that coordination. Dr. Beers, I can't recall if it was you or Dr. Boudreau. Why might a charter school opt out of the health services program?
Many of our charter schools use different buildings that do not meet the criteria. So there's a specific criteria for all schools, DCPS as well as charter, same criteria for the building. And so the needs that we have for you to be a part of the program, some of the charter schools have not been able to meet those based on the school, the actual structure of the building.
So it may not be that they don't want to participate, that they are not qualified to participate.
Correct.
And do you have an estimate of what's the going rate if someone isn't participating in this program and hiring, that they would need to hire an RN or a health tech elsewhere? Okay, what?
We lost to Prince George's County and their average is 120,000.
Wow, okay.
This is an RN number.
All right, got it.
But that would be a higher. So the contract rate, if they hired an agency to do it, it's typically about $80 an hour.
Gotcha.
So they are often unable to hire a full-time person.
Another question I would have for Dr. Bennett there is for charters that are not participating in the health services program, are we confident that there is coverage?
I'm going to let Senior Deputy.
I don't think they have complete coverage, but we've also expanded access to our school health management system, which is kind of like the EHR system that we use with our school health services programs. So we have made that available to the charter schools who are not part of the program. Not all of them have agreed to use it, but we do offer the same.
Do you have data on how many schools may not be taking you up on that?
We can share
If you could share that, that would be helpful.
Yeah.
Because this is now raising a question around how many schools are just out there freewheeling it. And like, oh, well, the building doesn't comply and we're not going to spend money on it. And God forbid something happens to a young person. And I'm not saying anyone is intending for that to be the case, but it would be helpful to have that data. You could share with the committee and then we'll get access to it.
Yeah.
The next is on coverage. So Dr. Bennett, we started with 90%. We're now down to 56% of schools that have 40-hour coverage. Do we have the schools that are comprised in that 56%? So which schools have 40 hours of coverage? And you may not be able to rattle that off, but if you could provide that to the committee,
we can.
I would like to know which schools are under that
We
category.
can do that. I will say that it's a dynamic process, right? Somebody calls out sick, somebody, we get a new student who's acutely ill at another school and we have to move. So it is a dynamic process because the student body is dynamic, but we can give you where we stand right now.
I'm gonna make the implicit explicit. That makes total sense. What I'm really interested in are the schools and the areas in the city where we know young people have more health needs among those schools that have 40 hours of coverage.
That's one of the reasons, among many, why the algorithm is not based on the size of the school, but on the size of the need in the school.
Love it.
So
Okay.
that is a disparity informed approach. It actually would result in more staff and higher level staff going to schools that have greater disparities because those children have a higher level of acuity than they would at another school. So even though another school like Deal might be in fact bigger, the number of fragile kids there may not be bigger, even despite that. So we look at how many kids have the highest need and where they are.
With that rationale, every school in Ward 7 and 8 should have 40-hour coverage.
So every school in Ward 7 and 8 doesn't have the medical. So remember, when we assigned a nurse, the nurse is assigned based on the medical needs, those four medical treatments that I discussed.
Okay.
The tracheotomies, the G-tube feedings, catheters.
So there seems to be some distance in what DC Health.
No,
It's the same. It's just
same.
we're at 52% now.
Yeah.
So again, we're at a triage level.
So where the nurse is assigned,
I got
it's
you.
based on
I
those.
got you.
And then we bring in the health technicians to support
Okay.
those other schools.
So we're going to get the schools that, in fact, if we can have data on all schools and their coverage, but more importantly, the schools that are averaging 40 hours a week, that would be helpful.
And I think it'll be more informative as we get sufficient staff on where we then fill the gaps.
Okay. It's my understanding, Dr. Boudreau, that every cluster, and there are 36 of them.
46
of them, they have an RN. And you have slightly more RNs. And so some of them are treatment RNs.
That's correct.
So
that's the model. We've had attrition, so we've moved. So every cluster does not have their cluster nurse. And the cluster nurse is the one who's responsible for the individual health plans, the 504s. That's the cluster RN.
So does every cluster have at least an RN?
Every cluster has a nurse.
That's visiting schools.
Yes.
Okay. What is the difference in function between an RN, an agency RN, the LPN, and the health technician?
Ideally, the agency RN would not do the 504s. So when we had those extra nurses, we tried to put the agency nurses there. Unfortunately, because of attrition, we did have to move some agency nurses into that cluster capacity. The cluster nurse has to be an RN. That nurse is responsible for individualized health plans, 504s. That's the one that does the traveling. The LPN or treatment RN is responsible, that's the one that's stable at the school that supports those medical needs that we discussed earlier. The health technician not only does the very important documentation that allows us to have the data that we submit, but also does the more routine level care. So asthma administration, diabetes administration. So they're able to do insulin administration. They're able to provide albuterol, the EpiPens in an emergency. They're able to assess when a child has anaphylaxis, and I shouldn't say assess, RNs assess, but the health technicians are able to identify the signs and symptoms of anaphylaxis and some of the other issues that come into
the disadvantage I'm hearing if a school maybe short of RN as it's in transition is more on the health plan and 504 coordination aspects.
But that nurse travels across the cluster to do that for all of the schools.
But otherwise, the health technician is permitted to provide every level of care that an RN would.
No.
So what is the difference?
So the health technician cannot do any of those medical care. So the tracheotomy, the catheters, the G-tube feedings, health technicians cannot do that.
You. Okay.
I think we're not as clearly as we can be, and my apologies, distinguishing the different tiers of need for kids. So children with special healthcare needs who have ongoing throughout the day medical needs. So not I need you to give me a medicine twice a day, but I might need you to suction my trach tube throughout the day. Those kids are a different category, and that is where we absolutely must have an RN at all times. That is different than a child who will have an intermittent need for an asthma inhaler or any number of services that parents provide at home, but we want someone trained at school who is not a teacher or somebody else to be able to support that need in school.
Gotcha.
So those are two
And
different levels of kids.
if I have a school where a student has a trach, that school likely will be prioritized for an RN.
They would absolutely be prioritized, not likely.
Got it. Okay.
Or an LPN, I'm sorry, we're saying nurse when we,
Okay.
it's someone who is trained to do that.
All right, I'm going to save my last 2 minutes for solutions, but very quickly, protocols. I've heard from some Ward 5 schools that they are not clear, from school leaders, they are not clear when the nurse, the RN, the health technician is showing up. What is the protocol there?
So we submit a bi-weekly school schedule by ward to DCPS central office and to the charter school board. The charter school board publishes that in their weekly bulletin. So every week the schedule is there. If I've had a number of school leaders who've reached out to me and said I didn't get it, and I'm happy to share that, but that is always available.
That's helpful. Sorry to interrupt. I'm just looking at the clock.
Minutes.
And Councilmember Henderson is strict on the clock. This is a charter school. So
Okay.
if that school leader is not clear when someone is showing up,
The charter school, the weekly bulletin from the
the
charter
weekly
school.
bulletin, that is helpful. If, let's say, Dr. Pedro was supposed to show up at the school today and she's sick and she doesn't show up, what's the protocol there?
There will be a morning email sent by the nurse manager no later than 8 o'clock in the morning, letting you know that person will not be there and providing you with telephone coverage.
Okay.
Or a new person, depending on the staff.
There seemed to be some ambiguity around schools alerting children for students with significant health needs, i.e. a student with a trach. Is there a classification of what, and it sounds like there is, of what constitutes significant health needs? Yes, and we will follow up on what's the protocol for a school to alert children about that. One other quick protocol question. If there is a transition in RN or health technician, they quit. What is the protocol there in replacing them at the school?
So in a nurse, because a nurse is assigned because LPN is assigned because there's a medical treatment. So a nurse has to be there. So we would have to move a nurse. We'd move that cluster nurse, that cluster RN who's right now roaming would have to be placed in that position until we are able to fill with a new LPN to serve that school.
Okay. I'm not fully.
I'll provide you some.
I
more
would
detail on it.
appreciate that. And then in my last 30 seconds, just coming back to solutions, I've heard clearly we need more money. Outside of money, what else is needed to ensure that this program is successful?
I do think there's some thinking and planning to be done. We're in a new implementation. That always means that there's going to be some space between our idea and reality, and we need to go together to really discuss where we can find efficiencies, where our idea of what would happen looked different, where communication did not work out as well as it could, which I think is a major issue that needs to be addressed in this program. So there are changes that I think we need to make. I just want to be clear, those changes are not a wholesale abandonment of the plan. They're improvements to get to some future more stable model.
Councilmember Henderson, if I could have 30 more seconds, and then the children's team. Outside of money, what else is needed to ensure that this program is successful?
Yeah, I mean, I think, and Robin and I have worked very closely together on this issue, and Dr. Boudreau did immense work over the last year, right? We went from 50% of our schools having access to the technology to have telehealth available to them to 100% of the schools. We need to figure out how to better leverage that for chronic disease management across the schools. Lots of our kids with chronic diseases are not well plugged in to ongoing care, which creates higher risk for them to have medical issues at schools. And so there is an opportunity for us to do that. It doesn't cost us more money. We have the staff in place. We need to figure out how to make sure they're used optimally and are really seeing enough patients, right? We certainly have watched the telehealth numbers continue to go up month over month since we've been doing this work, but there is opportunity for that to really be part of the long-term solution for making sure that all of the staff have the support that they need all of the time across the board, and students to really get the care they need.
I also think there's a communication with schools and parents that needs to happen so that people are not feeling so left out. We are absolutely in a critical moment. That's why we've been having really intensive meetings. But when we get past that critical moment, I think we still have some work to do in terms of making everybody understand what this is and why. When we have stories about someone calling an ambulance or something else happening, I think we need to be in better conversation to be able to have a discussion about that, about what the reasoning was, whether that was even the wrong thing. Honestly, if it was an EpiPen, thank God they did exactly the right thing. What I would have told the parent to do, what the parent would have done if they were at home. So just getting a sense of all of the different situations that schools are finding challenging or that parents are finding frightening would help us to be better communicators and to maybe shore up some pieces that feel medically sufficient to me or Dr. Boudreau, but are not sufficient to feel supported by the school or the parent.
And I also think that from the staff perspective, our staff has heard constant push that the health technician is not enough. I think they need to hear from the district that we support them, that we believe in them, that they're not just a fixed, but actually valuable members of the community. That's why we're seeing some of the attrition we're seeing. They don't feel recognized and seen. And I think when the schools say they don't want a health technician, when leaders are saying that, when parents are saying that, that is hurtful to the person. And so really embracing them as a valuable member of the community, I think will go a long way to the retention.
Received. Well, thank you all for your testimony.
Thank you again for that. And I would just say, Dr. Boudreau, I mean, looking at the numbers of health techs that you had in August, September to the health techs you have, something happened where a lot of people decided to do something different. And I think we need to figure out what that is. I think part of it is understanding, is our salary competitive in terms of what we're offering? I was telling Ona, you know, at the same time we're having this conversation in the long-term care space, we're talking about how much we pay direct care workers. And I don't ever want to be in a situation where DCPS actually had this problem where they increased the pay for substitute teachers. They didn't increase the pay for paraprofessionals. And then you saw all your paras was like, oh, okay, I'll become a substitute because I can get paid more for doing the exact same. Well, paras were doing more, but it's sort of this balance. So I don't want us to sort of get off track on that front. How often are all of y'all communicating? Or Children's and DC Health communicating?
Multiple times a week.
Okay. Got to be closer as we get through this triage period. And I do want to say that you have been responsive to the questions of the committee when I've certainly raised them. But I think we also, in talking about communication, the fact that you guys communicate to central office and to the public charter school board and not directly to the schools could be part of the issue, because it's like a long game of telephone. It never makes it down to the person who is the front desk person at the school, who is going to be the one who's dealing with the kid when the nurse isn't at school that day or something to that effect. So we just got to figure out those pieces. All right, we got some follow-up questions. And luckily for DC Health, we'll see you in a couple of weeks for performance oversight, so we can check in on some of these things. So lovely. Okay, so we want to get a breakdown of the grant budget and spending. So what percentage is on RN, LPN, health tech staffing? What percentage of the funding goes to AOM training, telehealth services, health suite maintenance, and administrative costs? Just get that breaking out. the market analysis before budget season, which would be super helpful. Let's keep a discussion going about having a deadline for construction of new health suites for DC Health and Children's. We're going to have to bring the public charter school board into that conversation. And I hope they won't be testy about it, but we'll see. I think there was a request from Councilmember Parker on data on which LEAs do not participate in the school health program and don't have health suites. A side question for DC Health. If I am a charter school and I'm contracting out with my own nurse, do you inspect my health suite? Like if I have a health suite, but I'm not part of the program because I got my own person, are you looking to see whether or not it's up to snuff?
It may be assessed by our health regulations unit as part of the school process. If they're establishing a new unit, but it wouldn't be reviewed by our school health suite staff.
But somebody at DC Health is looking at it to say, you have a water source.
As part of like,
They
yeah,
should
the,
if told that you are using it for clinics.
Okay.
yeah,
All right.
DGS is involved in those types of inspections as well.
For charter schools.
We'll clarify.
Okay, because they didn't even want us in there to check lead in the water. So we need to check on that. Updated data on which schools do not have 40 hours of coverage. So both the goal and the current staffing. And Councilmember Parker asked, what is the protocol for a school administrator to notify children that they have a student with a severe health needs? That just came in. Okay. We'll follow up with email as well. So this concludes our oversight roundtable for today. I want to thank everyone who offered their testimony. And for those who are listening, they're like, you asked a bunch of questions, but there's no resolution here. This is an ongoing process that we're gonna, this is part of it. For anyone who was not able to attend and speak at today's hearing, we will accept public testimony until Thursday, January 18th at 5 p.m. You may submit your statement on the council's hearing management system online. The committee will hold its next public roundtable on Wednesday, January 10th at 11 a.m. We will consider several nominations to DC Health licensing boards. So specifically the Long-Term Care Administration, Professional Counseling, and Occupational Therapy. On January 18th, this is like kind of breaking news-ish, sort of, because the council technically hasn't voted on it yet, but that's fine. We kick off our fiscal year 2023 performance oversight hearings. The schedule and instructions on how to testify will be available next Tuesday, we hope. The time is now 1:04 p.m. and this roundtable is adjourned. Thank you so much.